Thank you for joining us.
Recording in progress.
Thank you for joining us for day 2 of the Advancing the Science of Community Engaged Health Disparities Research virtual workshop. We just wanted to go over a couple of brief housekeeping reminders. Tatiana, may I have the next slide, please? Wanted to remind you that this workshop is being recorded, and please stay muted with your camera off unless you are speaking. And also for the attendees or audience, you may type your questions in the Q&A box if you have questions for our speakers. Thank you.
Thanks so much, Rashawn. Welcome everyone to the second and final day of our workshop on advancing the science of community-engaged health disparities research. My name is Maliha Ilyas. I am a program director in the Center of Translation Research and Implementation Sciences in the National Heart, Lung, and Blood Institute. I, along with Dr. Fernando Bruno, chaired the planning committee for this workshop. I'd like to start by thanking everyone who made this workshop possible. Our leadership at the National Heart, Lung, and Blood Institute, with support from our colleagues at the National Institute of Minority Health and Health Disparities, as well as the National Institute of Aging. Our dedicated planning committee with Dr. Mary Masterson, Dr. Crystal Hill-Pryor, Dr. Rebecca Roper, Dr. Amir Katipov, and Dr. Fernando Bruno and myself. Our hardworking workshop support team led by Rashawn Jones, and our AV support provided by Amir Ahmadi and Tatiana King. Thank you all. For those who were able to attend day 1 of our workshop yesterday, can hopefully attest that we had some great discussions around lessons learned in community-engaged health disparities research, planning for and assessing meaningful bi-directional community engagement, and addressing health inequities in various communities through community-engaged research. We're learning so much from this workshop, but some lessons we learned even before the workshop started, while we were planning for it. For example, several panelists and speakers pointed out during the planning phase that the title of our workshop should have been Advancing the Science of Community-Engaged Health Equities Workshop Research. As they said, we should aspire to higher goals, and only then will we be able to come close to achieving them. So we look forward to learning more and more from today from yesterday and today. We have an amazing day 2 planned for you all. We have 3 sessions today, starting with looking at community-engaged health equity research from a global lens, followed by exploring the data science perspective as it relates to community engagement, and ending with a session on advancing inclusive excellence in community-engaged health equity research. All 3 sessions have an impressive lineup of chairs and panelists, so please plan to attend all if possible. Dr. George Mensah will be providing some welcome remarks, while Dr. Lisa Cooper will be giving the keynote address today. The day will end with Dr. Jinji Zhang providing some closing remarks before my colleague and co-chair, Dr. Fernando Bruno, closes out the day. As always, please put your questions in the Q&A box. Only the panelists and speakers will be able to unmute themselves and turn on their cameras. We request that all panelists and speakers stay on camera during the course of their panel, while others stay off camera to save bandwidth. Please bear in mind that we will not be extensively introducing our speakers and panelists. We request that you refer to our participant handbook that will be posted on our site for detailed bios on all our excellent participants. I will announce transitions throughout the day, and with that, I would like to hand the mic to Dr. George Mensah, Director of the Center for Translation Research and Implementation Sciences here at the National Heart, Lung, and Blood Institute. Take it away, George.
Malia, thank you very much. You always give such clear instructions, so thank you, and I'm going to follow your instructions. Ladies and gentlemen, my name is George Mensah, and it's a real pleasure to be with you this morning. On behalf of the National Heart, Lung, and Blood Institute, I want to welcome you to this second day of our workshop on advancing community-engaged health disparities research. Maybe because Dr. Ilyas mentioned it, I should touch a little bit on why the health disparities research disparities is in there. Some of you know by congressional act, we have a National Institute for Minority Health and Health Disparities. So we are required to use the disparities word. And Eliseo would give you a long lecture on why that's important. But we completely agree with those of you who had the comment. Health equity is the aspirational goal. And we're just delighted that you've chosen to be with us yesterday and this morning. And I really want to thank you for your participation and for your interest in our Institute's mission, and especially in this workshop. I should mention that our workshops really constitute a very important tool for us in advancing the science and the research we support in the extramural environment. Many of our major extramural research activities and initiatives have had their origins in NHLBI workshops like this one. But it's also important to emphasize that developing initiatives and developing funding opportunity announcement is not necessarily the goal of our workshops. The critical component of the goals and objectives is the gaps in our research and the unique opportunities for the future that you help us identify. That's what's really crucial as we chart the future of NHLBI funded research. So please, as you go through the second day, the unique opportunities that you see and the gaps that you think NHLBI leadership, and in fact, all of NIH leadership can play important roles. That's what we really want to hear from you. And we couldn't have a better keynote speaker than Dr. Lisa Cooper from Johns Hopkins. As Malia said, we intend to be very brief in our descriptions. So even for Dr. Cooper, I'm going to have to be brief. She's very well known to this audience. And of course, details of her accomplishments are in the participant booklet that Dr. Elias mentioned. But let me mention at least two or three because it's important for this workshop. Dr. Cooper serves as the director of the Hopkins Center for Health Equity and the Urban Health Institute. And so the aspirational goal of equity, she's right in the center of it. But she's also one of the very few people I know who have two separate endowed professorships. She has the Bloomberg Distinguished Professorship at Johns Hopkins, both at the School of Medicine, the School of Nursing, the School of Public Health. But she's also the James Fries Professor of Medicine in the Division of General Internal Medicine. So whether you're talking about nursing, primary care, internal medicine, public health, she's really at the center of all of it. And it's a real pleasure. Most recently, just last week, she received the American Heart Association Distinguished Scientist Award. So it's a real pleasure for us to welcome Dr. Lisa Cooper, who's going to give our keynote lecture on closing the gap between knowledge and health equity, and share with us on future directions for community-engaged health disparities research. Please join me in welcoming Dr. Lisa Cooper. Lisa, over to you.
Thank you. Thank you so much for that very kind introduction, Dr. Menza. And thank you to all the conference organizers for inviting me to join you today. It's a pleasure for me to talk to you today about a topic that's close to my heart, which is community-engaged research to address health equity. Next slide. These are my disclosures, mostly grants and a few consultation fees. Next slide. So I want to start out by talking about this gap that we have between knowledge and equity. And what we know is that over the past few decades, there have been amazing breakthroughs in science that have advanced our understanding of human health and disease. Yet the benefits of these discoveries have not been fully realized in terms of the health of our population. And it's most concerning that the groups that have experienced social and economic marginalization are even less likely to benefit from these discoveries. So although we still need more knowledge about what the efficacious and effective approaches are and basic biomedical therapies, we have an opportunity right now to bridge the gap between what we know and our progress in addressing health equity. And to bridge the gap in implementation, we really need to use transdisciplinary research along with dissemination and translation initiatives to enhance the effectiveness and the sustainability of evidence-based approaches. But foundational to all these efforts is better engagement with the communities we serve, all of the communities, but especially those that experience health disparities. So next slide. So I wanted to start out with 5 proposed steps that we can engage in as we move towards the future of community engaged research to advance health equity. The first is operationalizing community engagement. The second, moving partnerships towards true collaboration and shared leadership. Number 3, building capacity for community engaged research. 4, fostering greater local and global bidirectional learning. And 5, moving from engagement to empowerment and equity. So let's start out with our first step, which is operationalizing community engagement. What does it mean to operationalize something? It means to put it into use, usually by defining all the relevant variables. That's removing any ambiguity, so there's really clarity around what actions need to be taken. And also it makes indicators measurable, right? So we really want to do more of that, I think, as we move forward in community engaged research. Next slide. One of the first steps, although there have been, lots of people working in this space, but the most recent significant effort around operationalizing community engagement comes from this conceptual model that was put forward by the National Academy of Medicine's Organizing Committee for Assessing Meaningful Community Engagement in Health and Healthcare Programs and Policies. So this is a wonderful conceptual model which centers community engagement and core engagement principles. So you can see those in the center of the slide. And then sort of radiating outward from those are the meaningful domains and indicators of impact within community engagement. So I think this is an excellent beginning to operationalizing community engagement, because we can't do it if we don't know exactly what we mean. And then we can't measure, how well we're doing it, and we can't link it to any important outcome if we don't have it well operationalized. So, I think this has been a very helpful model. What it shows is that if we engage in the core principles of community engagement, that what we should be aiming for is strengthened partnerships and alliances, expanded knowledge, improved health and healthcare programs and policies, and then ultimately thriving communities, right? And so we can reach health equity, our vision, through transforming systems. It's not just changes in individuals, but changes in communities and in systems. And so these are the important domains. So next slide, I'm going to try to give you an example of, or a few examples of how we really, codify and really operationalize what we mean. So these are some community engagement principles that have been described by a number of people in the field, well known, but Melody Goodman and colleagues have done a lot of work developing measures and indicators related to community engagement. So this one spells out the 8 engagement principles. And you can see here where, for example, there's a focus on community perspectives and determinants of health is a principle. And what my team and I have done at Johns Hopkins is that what we've tried to do is to really have people think about these key questions as they're trying to embody these principles. So this guide we developed basically is something that we gave our community engaged researchers to use, and also gave people who we assigned to their teams as community engagement coaches to use as they observe their interactions with community members and other stakeholders. So do the community members have an opportunity to discuss their viewpoints and to express concerns that impact health in their community or organization? So that's just one example. When you go through the rest of these, you can see that what we try to do is to have people think about specific behaviors that they would engage in that would demonstrate that they were embracing the principle. So you can see the principles: partner input is vital, partner sustainability to meet goals, foster co-learning, capacity building, and co-benefit. Next slide. These are the other principles: building on strengths and resources within the community, facilitating equitable partnerships, involving all partners in the dissemination process, and then finally building and maintaining trust in the partnership. So you can see where it's wonderful to have these principles, but some of us have been working in this field for a long time and we feel like we know what we mean when we say this. But as we try to explain to others what it is we're doing or to train other people, how can we actually tell them concretely what it looks like when we're embracing these principles? So hopefully this gives you an idea of how we could move in the future towards better operationalization. Next slide. So this slide is just an example of a study that we have been doing at the Center for Health Equity at Johns Hopkins, where we took some of these indicators and we measured them. So we actually did a cross-sectional survey study between December of 2019 and June of 2020, where we surveyed our community and academic partners in our community academic partnership. We measured demographics, health equity work experiences, and we used some of the measures that have been developed to quantify these community engagement principles and partnership processes. And then we also measured the social networks among the members. And what we found these are preliminary results, not published yet, but community members really rated the quality of community engagement and in some domains, though these are some of the domains: synergy, leadership, administration, and overall satisfaction with the partnership. They rated us pretty high, so 4 out of 5. But there was one area, decision-making, that was rated less than 3.5. So this gives us an idea of, something that we need to work on. And we also learned that participants expressed the desire for more engagement with diverse communities. They felt that we didn't have adequate representation of some communities within our partnership, and that they also felt that we needed to move beyond our regional area into interacting more with national organizations. So this kind of gives you an idea of what the future of community engagement might look like: stronger decision making, more engagement, more diverse engagement, more opportunities for learning across this national spectrum and maybe even beyond. So next slide. So another way of codifying and operationalizing community engagement, it's not only individual behaviors. We also need to think about institutional practices and policies, right? So, these practices are adapted from the Carnegie Foundation's classification for community engagement. And we actually use these to inform a process at Johns Hopkins, where I was asked to lead a community engagement committee that was part of a roadmap for diversity and inclusion. So, one of the things we said was that it's really important to institutionalize the institution's commitment to community engagement. So what does that mean? That means things like having a mission statement that includes community engagement as a principle and as part of one's mission, having guiding principles that the institution uses, having common definitions, so that it becomes the part of the way the institution does its work, whether it's through research, whether it's through teaching, whether it's through service. The second thing we said was that the institution needs to have a formal infrastructure and to enhance financial investments to advance community engagement. So it's not, okay to just say, well, yeah, community engagement is important to us. Well, do you have an office that is responsible for coordination of activities? Are there transparent and regular reporting strategies for your investments in community? So that's how you operationalize it. We also said that there needed to be an institution-wide framework for resources, for training and professional development, for faculty, staff, community partners, and institutional leaders. So, what opportunities are there available for whom and in which domains? And are they service? Are they research? Are they teaching and learning opportunities? And then we also finally said that we need to improve student competencies and student engagement. through greater exposure to high quality community engagement research, practice, and service. And so that concretely looks like providing real world opportunities for students and giving recognition and scholarships and awards. So this is another example. So next slide. So the other thing we need to do to operationalize community engagement is to make sure that we are actually evaluating it. So how do we do that? First of all, there are very few validated measures that exist. One of them is the REST, or the Research Engagement Survey tool developed by Dr. Goodman and colleagues. So we need to develop more valid measures on the individual, interpersonal, partnership, and institutional levels. The other issue is that there are few dimensions of community engagement that are well understood. So you saw those dimensions on the model. Some of them are better understood than others. We've done a great job of understanding what it looks like when people have trust, but and when there's power sharing. But there are other domains that we don't have adequate measures for. Now, third, the studies that do exist evaluating the impact on community engagement lack systematic reporting and methodologic rigor. So we need to really systematically describe the goals and characteristics of our partnerships, the methods we use, and how we evaluate them. And we need to employ longitudinal designs so that we can link these measures to important outcomes, to the community and to individuals, right? And to policymakers, important outcomes to everyone. Okay, so next slide. So now we're going to talk about the second step that we need to take in the future of community engaged research, and that's moving our partnerships towards true collaboration and shared leadership. Next slide. This slide, it shows a continuum of community engaged research. So, so in many cases, people are doing what I would think of as outreach, where there's some community involvement, but the communication flows from one person to the other, but it's primarily about informing people, right? And so that's one level of community engagement. The next level, we would say, would be more consultation, where there's more community involvement and the communication flows from the community to academics and then back, but with a focus on getting answers, right? And so there's a little bit more movement reciprocity there. Involvement is when there's even more community involvement, where the communication flows in both directions and there's more participation by academic and communities on in the dialogue and in the work. So we would say that's community involvement. I think really where we want to aim to be is more where in the area of collaboration and shared leadership. So collaboration means the communication is bidirectional. There's partnership on every aspect of the work. The outcomes are not simply just about doing a project, but they're about true partnership building and trust building. And then shared leadership, I would say, is the zenith of community engaged research, where we have a bidirectional communication, but the final decision making is actually at the community level. So we really can then impact broader health outcomes by engaging more deeply with communities. So I think hopefully we will be moving our partnerships more towards collaboration and shared leadership. All of this depends on sort of the resources and capacity, right, of the partners. And we recognize that not everyone might be prepared to do that, but that's ideally where we would want to be. Next slide. So why do we need a more broadly defined community engaged research continuum? Again, this will allow us all, researchers, community members, organizations, to really readily identify where are we on that continuum, to sort of help us figure out where the appropriate access points are to be on the continuum, depending on what our contextual factors are. So what resources do we have? What are the problems that currently exist? Where are the policies and where's the support for the work we're doing? And then finally, it will help us in determining what actions we need to take to progress on that continuum. Okay, next slide. So again, as I've said, the zenith of community engaged research is community-based participatory research, which is more in the collaborate and shared leadership space. And this has been described as a collaborative approach that equitably involves all partners, recognizes the unique strengths that each brings, uses a topic that is of importance to the community. And the key here is that we're combining knowledge with action, not just knowledge for knowledge's sake, but there's real action to achieve social change, right? So that's where we're aiming for. Next slide. So the third step is now building individual and institutional capacity. So, so we're operationalizing community engagement, and now we're moving, more towards collaboration and true shared leadership. But in order to do that, we have to build capacity. And so we need to focus more on that, not only amongst ourselves, but among researchers who haven't traditionally used community engaged approaches, because we know in order to advance health equity, it's going to be about all researchers beginning to take this lens to their work. So how do we build individual and institutional capacity for community engaged research? Next slide. I call this the 3 R's of community engagement capacity. So I show this iceberg figure because we know that when we're engaging with other people or with other groups, that there are lots of things that we can see on the surface, right? And those are things that it's good for us to know about. But if we really want to build our capacity to engage with people, especially people who are not like us, we have to be aware of the things that are below the surface. So the beliefs, the preferences, the values, the attitudes, what people think about what roles they should have, all those things. And the reason for using the iceberg metaphor is just that if we're not careful and we're not aware of those things below the surface, we can really, end up causing harm, right? So in order to overcome the danger of those, not knowing what's below the surface, I say we need to build our ability to be more respectful, to have more trustworthy relationships, and we need to be cognizant of the need for resources. So what do we mean? Like respect, we really need to think about what the diverse experiences are and perspectives are, and cultivate that respect, right? All of our work should reflect knowledge of historical and cultural values and meet people where they are, right? We need to use holistic approaches over disease-specific approaches. We need to leverage community wisdom. Building relationships, we know we need to teach people how to do this better, help them realize that it takes significant investments of time and clear communication. Realize that this is dynamic and evolving, that, the extent to which we will be truly engaged with communities is based on the extent to which we actually are listening to people and aligning our work according to their needs and priorities. We must engage everyone, right, in the process. And then the third thing I would say with third R is realizing that we have to leverage resources that exist. They may be strengths that exist within our communities, but that there are times when not having certain resources can be challenging. And then if we don't sort of recognize that and support people where they need to be supported, but then also benefit from their innovation and their creativity, that we won't be, maximizing the resources that are available to us. So the 3 R's of community engagement capacity. Next slide. This slide sort of talks again about the institutional piece of capacity building. So, I talked before with you about the different domains of institutional, operational definitions of community engagement on an institutional level. Well, how can we build capacity so that it's actually embedded into the mission, and that, that we are actually setting up an infrastructure, and that we actually have programs that are tailored to address all these issues? Once we have those programs, what are we going to teach people? So I usually say that, I think that there are 2 main domains, and they are relationship centeredness and cultural competency. So on the relationship centered piece, we need to teach people about more self-awareness, help them understand how they need to know more about their patients, their research participants, their colleagues and partners. Give them skills in participatory communication. Show them what it means to be, what it looks like to be respectful. help them identify how to work towards shared values. On the structural competency piece, that means people need to understand more about the structural factors that contribute to health inequities and to social injustices. They need to build partnerships. So it's not only about individuals, but like, how do we set up groups for collective action? Our organizations need to be more transparent. We need to give people what those practices are for transparency, disclosure of information, clarity of communication, right? Frequency of communication, reliability and competence, right? We need to provide resources, funding for health disparities research, and make sure that there's diverse participation in all of our projects and diverse leadership. So that's what it looks like to build that capacity in order to enhance our trustworthiness, and which is, ultimately what we want in order to advance health equity. So, these are some recommendations that have been given in the article by myself and Dr. Cruz, and then also by Dr. Consuelo Wilkins and Dr. Philip Alberti, an excellent guide to capacity building for institutional strengths in community engagement. Next slide. What do concrete strategies and tools look like? Online training modules on community engagement that people can access easily and that give them the basics. Examples of how people can do recruitment and how they can onboard community members into community advisory boards, allowing community members to give testimonials and sharing those broadly, quarterly newsletters, a website that is easily accessible and that has information that is important and acceptable and relevant to people's needs. Instruments to evaluate partnerships, so concrete tools that we can give people to build capacity. Next slide. So I'm moving on to the fourth. This is the fourth of 5 now. We need to enhance local and global bidirectional learning. So we can't do this work in isolation. So let's talk about what some examples of that might look like. Next slide. So these are just some examples of studies that we've done in Baltimore, where I would say we've done a lot of local learning, where we've learned from one another and learned from different projects about really what works well in community engagement. So a lot of this work has been funded by nhlbi and also by NIMHD. These are clinical trials where we engaged with health systems, where we engaged with grocery store owners, we engaged with patients, family members, community-based organizations, for example, those that train and employ community health workers. We worked with community health, federally qualified community health centers. We've worked with recreational facilities, IT companies that are interested in using health IT to better measure blood pressure. We've worked with home visiting programs for moms. And so we learn from one another about what strategies work best in which settings, who are the valuable and important voices to include in all of our activities. And so I think having a network, and so that's what we have within the Center for Health Equity, is we have our network, and we have community engagement councils for each of our individual projects, and then we have a center-wide community advisory board where we have members that come from all the different projects, and there's a lot of learning that takes place in our quarterly meetings. I think we're going to move on to the next slide so I can tell you more about some other networks. So that was a local network just in the Baltimore and the Mid-Atlantic region. This is a network that I was a part of that was also funded by NIH, called the Centers for Population Health and Health Disparities. Funded several centers across the country that were advancing health equity, all with community engagement being a core component of it. So you can see that there are different types of communities involved here. There's rural, urban, there are different, there's African American, Latino, American Indian. We have immigrant populations that were engaged in this work. So we could really learn from one another about these different approaches in different settings around the country. And you can see here when we wrote our perspective article that one of the main lessons learned was prioritizing community engagement and equitably shared power. Next slide. This is another network, of course, that you've probably heard lots about, the NIH SEAL program, which has been incredibly successful, a research community of practice that has been leading outreach, engagement, and inclusive participation in racially and ethnically minoritized communities that were disproportionately affected by COVID-19. Incredible network and learning community of all these different partners. You can see, you can imagine how much innovation comes out of this and how quickly it can be spread when we have these networks. Next slide. Yet another network, this one funded by the American Heart Association, called Restore, that is focused on hypertension. And one of the key pieces of this network is to partner with Black communities to mitigate the impact of negative social determinants of health on blood pressure. And then also to disseminate these findings to policymakers and stakeholders. So you can imagine that it's really been important for this network for us to have a huge community engagement component. We have a community engagement core, we have an overarching community engagement committee, and we have tools and strategies that we share across the 5 projects that are part of this network. Next slide. Yet another one, the Health Equity Action Network, funded by NIMHD, National Consortium of Health Researchers and Community Partners. And we're fortunate at Hopkins to have one of the centers called MATCH, the Mid-Atlantic Center for Cardiometabolic Health Equity. Next slide. So then there's also the local global learning piece. So one of the things I read about in a systematic review of community engagement efforts is that one thing that the researchers found was that high income countries actually use a lot less community engagement, particularly around COVID-19. And that was really, there were a lot of the innovation and best practices was occurring in low-income countries. And so I think one of the things we need to realize is that even though we have a lot of resources and technology and excellent institutions, that we don't know it all, and so we can translate what we know and share that knowledge with people in low-income countries, but they can teach us a lot. So one of the ways that we've engaged a lot in bidirectional learning in the local global setting is that we have projects. For example, we have a project called the Adinkra Study that takes place in Ghana that actually uses some approaches that we used in the Rich Life Project here in Baltimore, related to training of staff and how to measure blood pressure accurately and using community health workers. But we learned a lot from our project in Ghana about how mobile telephone technology could be used to help people communicate more effectively with their primary care team, and that they could report side effects and concerns around medications, which we weren't actually using in the US, but we had to use it in Ghana because they didn't have as many healthcare personnel there. And the doctors couldn't afford to see all those patients for follow-up visits. They had to have community health nurses, and they had to have that communication going on to really effectively manage the whole population of patients. We also have bidirectional learning with some organizations in Uganda where they've been doing a lot of using community advisory boards for years to address the issues around HIV inequity. And we learned a lot about how they did that. And we co-developed the prototype of a toolkit that would help people who were trying to develop and sustain community partnership. Next slide. Finally, we have a seminar series at Johns Hopkins called the Health Equity Jams sessions, and we hold special events. So this particular special event was around local lessons and global applications. So we had a panel discussion of researchers and community partners from the United States as well as other parts of the world, working in Asia, working in Africa, working in Latin America, talking about what are some of the common lessons, what are some unique factors, how can we learn from one another. Next slide. So this is the last step, which I would say is from engagement to empowerment and equity. So next slide. So what are we talking about when we say engagement? It's one thing for us to engage with community, but it's whole another thing for the community itself to become very engaged in the whole issue of health disparities and health equity. And so I thought this was a nice depiction of the different ways people can become more civically engaged. And I was really thinking about this a lot because of, this time is, since we've just had midterm elections, and, we're starting to see, even though, many people probably knew this for a long time, but the more civically engaged a community is, the better their health is. So civic engagement, the research has shown that on an individual level, it's good. It improves mental health. It improves health for individuals to be involved, whether they're involved, in an organization, participating in advocacy or education, whether they are involved in directly serving communities, volunteering, things like that, or whether they're involved politically, voting, writing letters to policymakers. So we know that that's important. So there's so many different ways our communities can be engaged. But as community engaged researchers, how much do we actually focus on, helping our communities be more civically engaged? Because at the end of the day, it's not going to be just research, and it's not going to be only our advocacy that brings about change, but it's really going to be about communities getting involved to make sure that they are using the evidence that we generate to really bring about change in these structural factors, right? So I think we really need to move towards doing more of that, empowering people through civic engagement. Next slide. So what does it mean when there's empowerment in the community? It means that there's more capabilities around collective control. There's more power. And I loved this emancipatory power framework because the researchers described empowerment as being power within. So that's like, what are the capabilities that are internal to a community that drive their collective control and action? What is the power with? So they have power together because they have the ability to build alliances and act with others to achieve common goals. The power to, so the capabilities to establish spaces for collective decision making and to manifest this collective control, and then power over. So then they have power over institutions, and they can exercise that power over, decision makers, right? So power within, power with, power to, and power over. Next slide. And so how can we as community engaged researchers promote more civic engagement and community empowerment? So I've described this on 3 levels, and this is a commentary that's going to be coming out later this week in JAMA Health Forum. My colleagues and I have said we need to do this on an interpersonal level, an organizational and community level, and on a societal level. So on an interpersonal level, we strengthen our working relationships with our community members. We express concern about what's happening in the community. We advise community members about what the personal and social value it is of them participating in civic groups and voting. On an organizational level, we form and support groups and networks, advisory boards. We provide institutional workshops and training. We use research methods that are centered on social justice, participatory action research. And one example of that is what I've shown here, Seated at the Table. This was a photo voice project where we got the perspectives of Baltimore City residents on what they felt like the food environment was like in their neighborhood. These are people with hypertension. And we wanted to hear that from them and have them take pictures and show us what that means, but then to use that information to bring about change with policymakers. So we held a community forum where we had policymakers who were there, and the community members were able to use their photo voice stories to really advocate for the change they want to see in their communities. And then finally, at a societal level, we as researchers in healthcare and health need to build collaborations with other social justice professionals. How can we work with lawyers? How can we work with social workers? How can we work with educators, people in other spaces that are doing social justice work? And some of these collaborations are already taking place. There's an organization called Vote ER, for example, where health professionals have been working with people in numerous sectors. And they've actually created lanyards where people can, when they come to the hospital, they can scan a QR code and it tells them where they should go and vote. So those are some strategies. Next slide. And that, in doing that, what we can do is move from health disparities, where there are these avoidable differences in health, to health equity, where every person has the opportunity to achieve their full health potential. So thank you for your time. Next slide. I think that will be the last slide. Oh, just to put a plug in for my book. It's available at a 35% discount from now through the end of June of next year for those of you who are attending this meeting and listening to this lecture. So feel free to visit the Johns Hopkins University Press and read more about how you can get involved in advancing health equity. Thank you.
Thank you so much, Dr. Cooper. That was a very information-packed presentation. So much. I was taking frantic notes, and I'm so glad that we are recording this so that folks can hear it who were not able to be here to actually hear you live. So thank you again. We have a very quick question because we are slated for a break, but because we got this question, we wanted to really share that with you before we let you go. One quick comment from Ruby Camacho. She was very, very thankful for the resources that you shared about the local community engagement networks. And Luz Garcini has also said, fantastic presentation. Thank you so much. Lots of claps for you. But there's a question from Robin Zender. Do you really think all researchers should engage community? It's always been my thinking that there are definitely some researchers that should not engage community because they will just never understand community engagement and it will not be successful for them and may very well injure the community. Would love your thoughts on that. Thanks.
Right. No, you raise a very important point. Clearly, there are people who lack the skills and the correct orientation or appropriate orientation, I should say, for working with communities. So what I would say is that, ideally, everyone should be able to engage in community engaged research, but we realize that not everyone is going to have that ability. I think we should provide opportunities for people to get that training and to build their capacity to do that work. But we also probably need to hold people accountable. And so they need to demonstrate those behaviors and those actions that we talked about in order to be able to continue to do this work. So we, maybe that's part of it. The capacity building is training people, but then also having them demonstrate some level of competency before they engage in this work. And then maybe some people just end up doing more outreach or consultation and they don't really do the collaborative part. They turn that over to others.
Thanks, Dr. Cooper. There are a couple of other questions, but I see Dr. Mensah's hand raised. For those that we don't get to your questions, we will share them with Lisa Cooper offline and try to include them in our report somehow. But Dr. Mensah, would you like to ask a question before we go for break?
Thank you very much, Dr. Elias. Dr. Cooper, this was fantastic. So thank you very much. I had a quick comment and a quick question. And the comment is that I really should thank you on behalf of NIH and NHLBI, because early on in the pandemic, when we needed to demonstrate to our communities that there are people of color, and especially women of color, involved in this research and the safety of research, you are one of the first to allow NIH to use your photograph in our scientific pathway, and it was very, very effective. So thank you very much. The question for you is that you've given us a lot to think about, and there's a ton here that we can think about. One question that has bothered us throughout our community engagement effort is how do we measure the impact of all the work that we're doing beyond the process measures, how many meetings we have and how many town halls we have? Your thoughts on how NIH and NHLBI leadership can lead and advance the research in measuring impact of community engagement?
Yeah, so that's what I was talking about when I was talking about in the, the sort of operationalization piece. That's a tongue twister. I should think about not using that. But so I think it's very difficult, again, because this work has so many different domains, and that because we don't have a lot of validated measures right now, I think we need to use what we have. I think that we should think about, as we're doing our work, how we actually incorporate research questions around the community engagement process itself, and not only the interventions we're testing, so that we can use experimental designs. And like I said, longitudinal designs are good. We can do pre-post measures of things like, let's say you have different projects and you look to see whether engaging communities in a certain way actually led to stronger recruitment or better outcomes of the trial. I think if we think about using pre-post designs or even using sort of experimental designs in our approaches, so that we're not only looking at the specific medical intervention that we're testing, but we're also looking at the community engagement approach. Was it something that was less intensive? Was it who was engaged in it, and whether that influenced the outcomes? But I think that's what we need to start doing.
Great, thank you very much.
I see a question from my esteemed colleague, Dr. Aguilar Axiola, whose conceptual framework I referenced.
No, thank you so much. This was just as Dr. Mensah mentioned, a fantastic presentation. What a wonderful roadmap you are sharing with us. Very thoughtful, coming from experience and coming from genuine, involvement with communities. And I just wanted to thank you for not only the splendid presentation you made, but also including the National Academy of Medicine framework that we have been working on for almost 4 years. And just to let you know in the audience that there is going to be another installment in addition to the conceptual model, and that is the measures, the comprehensive review that we did, very comprehensive review. And there are going to be 28 measures that will be released shortly, and also impact stories, to put it in perspective with examples at the local level, with great diversity on that as well. But what a leader you are, and what a really contributions that you have made to the field. Thank you so much.
Well, thank you. I'm indebted to you as well, because your work has certainly guided me.
Thank you so much to all of our esteemed panelists and for their questions. And Dr. Cooper, again, thank you for kicking off day 2 with such an amazing presentation and really setting the theme for our full day ahead. Thank you so much. Lots of you can see hearts and clapping coming up, and we'll share the extra questions with you offline so we can get your responses and hopefully share them in our report for the workshop. But thank you so much. You can see all the adulation you're getting from the attendees. I'd like to announce our break now. So we are going to shorten our break a little bit. We're still going to come back at noon, so from another 8 minutes, but please do join us again for session 4, which is the first session for today, the importance of community engaged research in combating global health disparities. So please join us for an excellent panel discussion coming right up in 8 minutes. See you soon.
Excellent. See you, everyone.
Good afternoon, everyone. Hope everyone's back after a quick break, and we would like to kick off our first session of the day, session 4, which is going to be focused on the importance of community engaged research in combating global health disparities. And in order to kick off this panel's discussion, I would like to hand over to my esteemed colleague, Dr. Makita Williams, who is the Global Health Program Director at the National Heart, Lung, and Blood Institute at NIH. Makita, take it away, please.
Thank you so much, Dr. Ilias, and welcome everyone to session 4, the importance of community engaged research in combating global health disparities. First, I would just like to say I think it's very apropos to have this session after Dr. Lisa Cooper's keynote address, not only because she touched on the local and global bidirectional learning, but because she's also a Liberian-born person who knows professionally and personally what it means to really engage the community from a personal perspective and also from a professional perspective. So thank you so much, Dr. Cooper, for your great remarks this morning. I'd now like to introduce everyone to our esteemed chair and panelists for this session. I won't go into detail. As we've mentioned earlier, we do have a workshop booklet that has more details about the backgrounds for each of our chair and panelists. So first, I'd like to introduce Dr. Marcela Nunez-Smith, Associate Dean for Health Equity Research at the Yale School of Medicine in the United States. Our first panelist, Dr. Anna Makumbi, Head of Division of Chronic and Non-Communicable Diseases at the National Institute in Mozambique, as well as Associate Professor of Clinical Cardiology at Eduardo Mondlane University in Maputo, Mozambique. Our second panelist, Dr. Marshall Tulloch-Reed, Director of Caribbean Institute for Health Research at the University of West Indies in Kingston, Jamaica. And finally, Dr. Nikhil Tandon, Professor, Department of Endocrinology and Metabolism at the All India Institute of Medical Sciences, as well as Head of Capacity Building at the Center for Chronic Disease Control in New Delhi, India. And as our keynote speaker yesterday, Dr. Trent Adams, mentioned, we do live in a global community, and COVID has been an example of that. And so we've seen that science and disease have no borders. So health research, whether it's domestic or global, should ensure active participation of the community from the beginning to the end, and should be community-centered for maximum success. Our esteemed chair and panel will discuss important focal areas for community-engaged research in the global health context. As they are speaking, please be thinking about questions that you can be asking. You can put them in the Q&A box, or for our panelists and others, you can put it in the chat for Zoom, and I'll be monitoring that, and we will have a moderated question and answer period after the panelists and chair have their discussion. At this point, I would now like to turn it over to Dr. Nunez-Smith. Thank you.
Thank you. Good day, everyone. Yes, thank you so much, Dr. Williams, for that introduction and for moderating our panel today. An extra thank you, of course, goes to NHLBI for really elevating this focus on the science of community-engaged research broadly throughout this workshop. And of course, for our topic today and our panel, this is a topic that is very near and dear to me, and I know it is to our esteemed panelists as well. It is our hope that today's panel will provide a critical contribution and will deepen our understanding of the importance of community-engaged research in combating global health disparities. With the world's population officially hitting 8 billion today, this conversation seems especially timely. And as you've heard from Dr. Williams, we have several experts from around the world who have been leading research programs and initiatives through multiple challenges, of course, including the pandemic. And we're going to invite our panelists shortly to discuss some of the lessons learned and opportunities for innovation from their own work and perspective. But before we turn to learning from each of them about community-engaged research in this important global context, we're going to hear about work in Mozambique, in the Caribbean, and India. I'll take a couple minutes to provide maybe some context for this conversation and briefly share lessons that I've learned and still learning, but through collaborative research, through partnered scholarship that I've been part of in the US, as well as in the Eastern Caribbean for many years. And then I'll wrap by reflecting on how those experiences really inform my perspectives working with COVID-19. So as we know, we heard, community-engaged research exists across a spectrum of engagement levels, but the guiding principles, the values, they're really consistent regardless of the approach, regardless of the depth of engagement, respect, trust, that bi-directional exchange, the recognition, importantly, and valuing of varied expertise, always elevating community-placed wisdom, using an asset-based frame to lift the positive, and quite frankly, the often under-recognized assets that exist across every single community, and addressing those social, those structural barriers to facilitate full research participation. And this perhaps is the most important and the most difficult, really, but honoring the reality that in many of the settings where we work, communities have been exploited and they've been harmed in the very name of research. So here at Yale, at the Equity Research and Innovation Center, or ERIC, we aim every day to elevate community partner expertise in all of our research activities, and to always work really in service of those equity-seeking communities here locally, but also beyond. And the how we do our work, so that I know we're going to get into today as well, but the how we do our work is incredibly foundational for us. And over these years, we have learned time and time again that unwavering importance of sustaining, of nurturing partnerships really over time, and doing that through both formal and informal mechanisms. I want to share just a couple quick examples. So for almost 2 decades here in New Haven, we've worked with a steering committee, and it includes local community leaders and researchers, both to drive a health equity focused, community engaged project research agenda here in Greater New Haven. And this group meets monthly. It's actually meeting right now and has steered over these years more than 30 community responsive research initiatives, and along the way have developed several nationally recognized best practice models. And I want to share some work that the steering committee is doing currently. So we've recently launched this new initiative. It's the Community Health Equity Accelerator, or CHEA, another acronym. But through CHEA, we're piloting a new approach, again, to how we do our work. This model importantly transfers the power of budgeting, so resource allocation, decision-making, to those who have the requisite lived experience and wisdom in our communities. CHEA has a governing coalition. The governing coalition for every cycle determines the research question, also identifies the metrics for change, selects and funds investigators, and ultimately interprets findings and determines next steps. So the group is currently working on cycle 1, which is focused on a community identified priority, which is pediatric asthma disparity here in Greater New Haven. ERIC is also the home of the coordinating centers that support the NIH-funded Eastern Caribbean Health Outcomes Research Network, or ECHORN. And ECHORN is a multi-sectoral collaborative chronic disease research network. And within ECHORN, our flagship research activity is an intergenerational cohort following over 3,000 community residents in the U.S. territories of Puerto Rico, the U.S. Virgin Islands, as well as in Barbados and Trinidad and Tobago. And so through ECHORN, we have a governing board, and that group is also meeting today, actually, and they serve as our board of directors. They have set the strategic plan for ECHORN's research agenda, always anchoring on community-identified health priorities, research questions, the research approaches, the analytic interpretation, and our engagement and dissemination strategies. And so we're really excited by all the work done by our governing board, by all the investigators in the ECHORN network, and to see that ever-expanding diversity of research that exists in our portfolio. We're really excited to announce that we've launched a publicly accessible platform to share ECHORN-generated data more broadly. So in New Haven and in the Eastern Caribbean, we have found really just deep value in remaining nimble and flexible in order to stay responsive and accountable to our community partners. As I know the panelists will attest, this is not easy to do, and quite frankly, it can often run counter to the culture of academic institutions and funders. But prioritizing always the deliverables, the directives that are set forth by our community partners and experts in our work has really always led, every time, to the highest quality, greatest impact science. And really, at the end of the day, most of us are conducting research with that hope, right? In the hope that the findings from our work will be difference-making for individuals, for communities. And we know, everyone gathered today, that the process of research matters so much as well. And the implications of the how, as well as the what, are far-reaching. I mean, we saw this with access and acceptance of COVID-19 vaccines. It's essential. We had to, with intentionality, really place and center on community engagement and partnership at the core of the federal all-of-government response. And that was really the only pathway to connect communities successfully with scientific discovery. And just 2 quick examples there before I invite our panelists to join in. I would lift up the NIH Community Engagement Alliance, or SEAL, here in the U.S. context. That entire initiative strives to eliminate COVID-19 disparities, supporting researchers who are working with communities, those communities that have been the most effective. And the goal of SEAL, right, is to foster community engagement research in those communities hardest hit by the pandemic. But importantly, really often builds on existing community academic partnerships. And that same reality is true for the NIH's RADx Up initiative, also leveraging those lasting collaborations to speed the process of technology uptake and that connection to science. So those aren't the only ones, but both of those are real world manifestations of working with established and sustained partners to achieve transformative change. And to be frank, this is exactly why the top recommendation from the Presidential COVID-19 Health Equity Task Force that I was honored to chair is to invest in community-led solutions. So with that, I'll pause. I'm so very much looking forward to our conversation today. I know the knowledge exchange that will begin and will continue, I know, after our panel ends. We're all quite aware the challenges in this space are substantial. If we think about COVID-19, it's affected research programs. We face other realities to the research, navigating climate change, ongoing public health threats. Those all disrupt the trajectory of our work. But where there are challenges, there are most certainly always opportunities, and we will discuss all of those today. So with that, I'll say welcome again to the panelists. We're going to go in a round robin style. I have a set of questions really to gain your insights on this important topic. We'll keep an eye while we're in discussion on the time. We want to invite the audience into question too. So around 12:45 or 12:50 Eastern time, we'll turn to that. Are we ready? Yes, wonderful. So my very first question is around the barriers, right? The challenges that exist. And, you know, Dr. Tandon, I might turn to you first to kick us off here. But what are the barriers to successfully implement community engaged research as you have found them?
Thank you, Dr. Nunez-Smith. And thank you for putting me on the spot right at the very beginning.
My pleasure. You owe me.
So let me give you my perspective. I'm actually a clinically trained, clinically active person. So for me, it requires a very significant change of hats, going in from a situation where somebody who has an ailment comes to you for care versus going out into the community and seeking assistance, cooperation from a range of stakeholders in the community for doing the sort of work that you want to do. Now, that work may involve trying to come up with solutions for improving quality of care to those very individuals. But I think the biggest challenge has been to get all the stakeholders together, each one of them getting a very, very different perspective, each having their own constraints, each coming from a very different social context. And in a country like India, and I'm sure that happens in other low and middle income countries, the issue of a significant economic and educational heterogeneity between the various stakeholders, right? And as a result of which, what invariably happens is that you need to be able to convince a whole range of people using different approaches of what you are planning to do is with a genuine intent, that you really want to be a bearer of public good, and that there will be an initial skepticism across the range of stakeholders. And we've seen that because there is a perception that this is an outsider trying to come in to tell us what we should be doing, and we already know what is to be done. And I think that barrier becomes very significant. So you've got to do a really sort of formal assessment of what it is that each one of those are concerned about, and try and assuage their concerns in a language and a manner that they understand. And I think that has become very, very important for us because, for me as a practicing clinician, I might be more interested in ensuring that evidence-based medicine is being delivered, whereas the stakeholder in a small place who is not very well off economically, their primary concern would be a steady supply of free or affordable medicines. And you've got to reconcile these approaches. And similarly, if you're bringing the governmental approach, because in India, if you're going into the community and you expect government organizations to assist, is to overcome that healthy skepticism which most government functionaries have, that these academics think they know what they're doing, but they really have no clue at what's being done. So I think the most important thing is to believe that what you're doing is really for people's good, and also convince all the participants that really it is with an absolutely genuine intention that you're coming across. And once you manage to do that, you will get people on board. But till you manage to do that, I think it remains, on occasion, a very challenging task. I'll stop here.
No, thank you so much, Dr. Tannen, and lots of nodding from the other panelists as you were talking. I mean, you started articulating, I think, some really important barriers that are probably universally recognized. Of course, I hear in that the time, the resources, but also that skepticism that can exist. And so we have to name that. You started speaking to some strategies too, which we'll get to. But thanks for lifting those up. Dr. Makumbi, you want to add some additional context?
Yes, thank you very much for having me here. And I will start by saying I was agreeing with what my colleague was saying. And I think that one of the problems that we face in African under-resourced settings is that there are key differences in the way people view global health in the first place. So the way we understand global health as a partnership is sometimes seen as some north to south type of message, provision of support, and we see ourselves as recipients. And this is something that needs to be addressed when we are talking about engaging the community in global health research to combat disparity. And there are different dimensions to disparity too. So in the African context, because of the determinants of health that are involved and are really key for us to understand what we want to do in terms of health, there are many differences that must be taken into account. The views and perspectives of the researchers, even if they belong to that community or to a closer community, are very much different from what the community thinks, what the community expects, and also vary in the way the community sees the researcher. So assumptions of shared leadership and other co-development of research and all these concepts that we usually want to incorporate in community engagement and involvement are sometimes difficult. And yes, when we get a sense of the community, how they see us, we start establishing a sort of empathy with the community. It's many times easier, but still there are areas where we continue to have major differences in the way we communicate in the first place. A very big barrier is the way the community uses the tools and the different tools that they have to communicate, the rules, the role of each member of the community has a part of the society. And in some communities, the role of women, for instance, the role of the household holders. I'm used to do community research in very low income settings. So priority setting, as the previous panelist was saying, it's completely different. And to involve the community in setting priorities for research, I think that will always continue to be a challenge for us in Africa. And finally, there are financial aspects of the community that determine a certain degree of vulnerability that we should respect and should also take into consideration in trying to establish these equitable partnerships with the community. So I would end saying that for me as an African researcher working in African setting, there are some dilemmas of the local researcher who is working on global partnerships in doing research in these communities, because I'm also always thinking if truly I'm equitably sharing the power. And we have been doing community engagement, going outreach. Now that I've learned, it's probably more outreach than community engagement, because it's something that we need to do, because we feel that we do not belong to that community. We don't understand completely the language. We don't communicate the same way. But also how we can serve has a link between those who are really our partners from outside and the community that we are aiming to serve and that we theoretically belong to. So I will stop here. Thank you.
No, thank you. Incredibly rich. So important, I think, that we're holding space to name some of these challenges, right? And some of the barriers. For conversations I'm in, I feel like we're really going next level on this, because you're really lifting up a lot of the complication, big issues in terms of power north-south and paradigm shifts that are required, but also the challenges for investigators, for researchers serving as that bridge, and all the things that have to really be acknowledged in that. And so it really is essential to have investigators of a place working with people from a place, but not sufficient in and of itself, and presents other conditions too. I'm furiously taking a lot of notes. I hope I'll be able to read my own handwriting. And this is great. I'm gonna ask you, Dr. Tulloch Reed. I've known you a long time. It's wonderful to see you today. But maybe to add, and then help us walk towards some of the things that have worked, right? Because we always know there are going to be the barriers, there are going to be the challenges. It does no one a service to pretend that those don't exist. But each one of you has done incredibly innovative work to address some of the barriers we've talked about, and others still. So if you have to add to what your colleagues have shared, but walk us into the strategies you have found successful too, please.
Yes. Okay. Thanks very much, Marcella. So it's actually quite interesting. There was something that you said at the very beginning, which was around the whole issue of community engagement being countercultural to our normal research culture. And I think that's an important point that we don't want people to miss, because a lot of times when we're planning our projects, we're kind of always focused on the main outcome, the relative risk and the odds ratio, and getting to that conclusion about a statement on some theoretical matter. But exactly all the steps that are involved in moving from just a concept and an answer through involving people in the work to come up with that answer are quite critical. And I think one of the challenges that I have found in terms of community engagement is just that there sometimes seem to be fewer resources for that engagement process. I think generally there's a culture that has existed in the past where persons who are living outside of developing countries are a lot more willing to participate. There's a lot more trust and belief in the health system. And so the engagement takes place very easily, because once you ask, then they will come. But that is changing. A lot of things are changing, and that is one of the things that is changing. I think the culture is also another thing that we have to think about, because we sometimes the community, and that's another important point which came up, is that the community is sometimes not looking to engage us in a particular way, because when a physician or researcher comes in, the community's expectation is that you have been trained and you have the answers to why are you disturbing me. So these are things that we have to think around when we are engaging. But one of the things I've found recently is that not just the issue of the expectations and trying to meet the goals, but just that sometimes we are missing some of the resources that would help us to effectively engage. So for instance, in my department, you kind of think through the staffing and you say, okay, what do we really need? We need the epidemiologist, we need a statistician, we need laboratory scientists, but then, okay, but we do need a social scientist, but what's the most important? Or we do need to engage, okay, what do we need to engage? A research assistant, or do we need to engage a community worker? And sometimes these are the challenges that we have, or even when we're thinking about how we communicate with the population and engage them in some way. This is what we're doing, this is what we think we'd like to do, what do you think is a good answer, etc. Or communication strategies are often limited, because very often within a a small department, your focus is on the essentials. So even things that could help in the talk earlier about websites and materials that can engage people, we really don't have dedicated staff to do that. And so it's always sometimes a bit of a balancing act where you're trying to keep the funding going. You have a small department trying to keep the funding going, and the funding comes from answers, not from engagement. So that's very important. Even though to get the answers, we need to engage, but it's a little bit of a trick. And I guess that's one of the things that we have to try and figure out. For me, in my setting, I'm in Jamaica, which is relatively small, and I think it has one advantage, which is that you sometimes can't help but embed yourself within your society. So, I mean, you're going to the supermarket or you're going to run into people there. So that's one way of engagement. You're training a number of people who have become the leaders in, the different institutions. And so that's another way of sort of beginning your engagement or facilitating your engagement. I'm a practicing clinician, and I think that's also another way in which I'm able to engage. And I think one of the things that really helps is when you're not afraid to engage yourself fully. I think in different settings, we find where, there's a very prescriptive approach in terms of this is my role and my role ends here and my role begins there. In a smaller setting, you're in the supermarket and the patients will call to you, you're at work or you're walking on the road and people will see you, then you'll have to engage. And if you're very deliberate as well about engaging yourself in things that people are doing. So for instance, even thinking outside, okay, well, I don't engage with patients outside my office from 9 to 5, but being a part of a support group that has been developed where people can air the issues that are of concern to them. These are things that I think are quite helpful in putting us in a position where we can understand a little bit better what the community is asking from us. And then when we are ready, or when we have the opportunities, we can work together to come up with the answers that are needed to create solutions.
Great. Thank you. I love the imagery of you in the supermarket, fielding all the questions.
Yeah,
right?
I used to be in my shorts too, so that's another thing.
We could all identify with that. But thank you. This is really important. I've sort of double underlined your embed. I think that's really critical, right? Because everything you're saying is it's hard if you're on this walk with community to say you're going to turn that off, right? As I look around the panelists, this is always on. And they're going to be formal and informal ways, but it's making oneself really available is what I hear, right? Which is a whole different conversation, but a really important one, particularly when it comes to researchers and what you're doing. So really important strategies there. A lot of strategies starting to lift around prioritization in a limited resource context. I think that I've heard from each of you. I'm going to turn to you, Dr. McCamey, to continue our thinking around some of the strategies that maybe have you found helpful and you'd like to share with us, please.
Yeah, thank you. So working in communities which have usually very low levels of health literacy, at least for our way of interpreting their knowledge, because we are not able to interpret indigenous knowledge from these communities. It's sometimes difficult, but we find ways. And some of the strategies are really, as we were here discussing, to embed yourself, your team into the community. Stay with them, discuss with them. It's true that we don't know to do it maybe the proper way for community engagement and involvement, but every study has one preliminary step, which is to go there, understand, try to find ways to get the terms that we want to employ during our work from the community, the closest way to get the vocabulary to be the same among us. The second thing is really how we were discussing, to really be genuine about what we are going to do, but also how higher or lower their expectations should be. Because there are some degree of complexity in our studies, such as genetics sometimes, technology, that is not really the day-to-day life for those communities. So we need to know them first, to be with them. And I liked what Dr. Cooper was saying about the power within, etc., so that we can understand them and we can use that as an advantage to ourselves to start talking the same language and trying together to become partners in research. I mean, I don't have experience of really getting it to a level where we are really fully partners until dissemination phases, etc., because this is relatively new to our settings, this discussion about the science of community engagement. And I think that this is one of the reasons why we need to do research in our settings, to understand, to create models, and to be able to measure the impact of the community engagement and involvement strategies that we use. Sometimes we have problems with strategies that are top-down from us researchers to the community, because they bring with them some degree of not considering the community, not acknowledging the own know-how of the community. And this is something that is difficult for us clinicians. I heard one of my colleagues also saying, but it's something that we need to learn. So we need to do research in our settings so that then we can learn and we can interact appropriately with these communities. So no single strategy to share with you that has proven to work, but this is the way we really try to be part of the community, work with them, learn from them. And it's sometimes a process that changes with time, with the way they understand the studies. We are working with cohort studies, so we get to know them, they get more involved, we gain their trust, and things can change. So I think that we need to explore the different strategies at the beginning, but then surely we are able to find an interface where this relation between the research team and the community becomes really a partnership.
Yes, fantastic. Thank you. A lot there. So including, I think, that important note to us, the dynamism that is inherent in the work that we do. And so being really mindful of that change, but also the meeting people where they are, knowing where we are on the engagement journey, ourselves as investigators. A lot there. Dr. Tandon, strategies. You alluded to some earlier when you kicked us off.
So I mean, and again, in a country like India, there is often a very large gap between the sort of researcher and the community where research is being conducted. And for want of a better word, I think sometimes people from the community perceive the academic researcher as somebody coming from a totally different planet. And therefore, that conversation is very often the danger of that conversation going in parallel to each other. You know, they're talking two different languages. And in India, of course, the second problem is it's not metaphorically two different languages, but actually could be two different languages, because we have a few hundred languages out there. So that's another issue which really comes into play. So for us, what we've always done is, and I think the critical part when there's a community engagement is that even though I'm sitting in Delhi and let's say the work is being done a couple of 100 or 300 or 500 kilometers away, we try and ensure that the entire cadre of the staff which is going to interact with the community is hired from within the community, right? So there are people who belong there, who understand the problems, who speak the language in more ways than one. When I say speak the language, it's very important, because you may be saying something which may go so desperately wrong in translation that and can boomerang and really destroy an entire project. I mean, giving you a very simple example, we thought we were being very smart and we developed an application for accredited social health activists to work. We thought Hindi would suffice. I mean, Hindi is fairly common. And then we realized that, 50% of them actually didn't know how to read Hindi. And that was the end of that. We were set back by 6 months. We just weren't smart enough to have figured that. The second thing, of course, is to have a form, something like a community advisory board. So again, getting the elders from there to speak to understand what their concerns would be, to be also very clear that there may be certain taboo areas or no entry zones. You really don't want to go down those areas because then you'll create problems for yourself. And it's better to have that prior interaction with members of the community. Even if it's an informal community advisory board, I mean, you don't have to make it sound very grand, but that conversation is critical. And we've also benefited significantly by doing, whether you call it piloting, whether you call it formative research, but the first few months are just trying to get a sense of what is possible, what is the ground reality, what are the concerns that we're likely to be facing, and then navigating through that. And I think those are 2 or 3 things which have really helped us, get across in several instances where otherwise we would have been in serious difficulty. I'll stop here.
Yeah, thank you. Fantastic. I want to learn, I'm going to turn in a second to ask you for your future watch, right? Where we can go and where we're going. But first, I'm going to maybe do a rapid fire round robin from a question we had that came in from Dr. Cooper. I think it's really relevant to our conversation because we are enumerating, I think, a really strong list of areas where we should be seeking for that, seeking opportunity to address the challenges. We just talked about some very successful strategies. I'll share for everyone that Dr. Cooper's question is, have you and your community partners considered pooling or sharing of resources and personnel to enhance capacity? And this might be a little bit of some of the future work too, but maybe we'll just do a quick round robin, sort of 30 seconds from each of you. If you'll start us off, Marshall, and then, we'll circle back to some other thoughts around how we can explore avenues maybe we haven't in the past, please.
Yeah, so I think for us, there are a number of things that we can tap into. I think one of the things is even with the Ministry of Health and the network that they have, and even for us, because we don't have a very strong or dedicated communication system, we often try to tap into some of their things. So we'll follow and tag and so on. I think that's one way. And then even because of the relationship we have, we do try to become involved in any community outreach projects or programs that they may be involved in. And then we are able to get support from them around a number of other things that we may need to do in communities. So I found that very helpful.
Great, thank you. Dr. Mukumbi.
So we have been using community-based organization, non-government organizations that are usually linked to those communities doing social work on doing the agricultural or other forms of development programs that usually know the community, are already embedded in the community. And the second experience that we are having now, for instance, with the non-communicable disease and injury of poverty network, is to use the voices of the patients themselves, those that are part of those communities that have their own personal experiences about living with certain conditions, and that help and support in taking our message to those communities, to specific groups, adolescents, women. So I think that this is the way to try to pull resources that sometimes we do not have in our own projects. Let us not forget that many times we have already the projects done when we finally go to the community to start this discussion. So we are too late there, and it's really how we try to do that.
Yes. Thank you. Dr. Tandon, experience pooling resources, all of us working in limited resource environments.
Oh, absolutely. I mean, I think individual investigators and even individual research teams are never going to be big enough to manage what you're planning to do. And we will invariably end up with a very narrow, maybe even a tubular perspective if we go in on our own. So we invariably will take the assistance. And I think all the examples given, including governmental organizations, not-for-profit organizations, civil society organization, patient champions, and also if you're developing technology, then having clearly a community-facing application. So it should not be a unidirectional application in which you're speaking to people, but there should be an opportunity for the community to speak to you so that you can get more inputs from that. So I think all of this is critical. Just sitting in your offices and doing this work would be the death knell of that research as far as I'm concerned.
Hear, hear. Good, thank you. That's a great question. Really appreciate it. I'm going to have one more question for the panelists before we open it up to all the folks who are joining us today on the webinar. I have many words underlined, circled, all kinds of things on this paper, but I have now circled and starred multi-sectoral, right? Because really, I think it's the right question. How do we pool the resources, and also how do we really reimagine where those resources can come from, and how do we also reimagine what resources even are? But being able to say yes between governmental partnerships and CBOs and philanthropy, and quite frankly, the private sector, maybe too, if we're all sort of on this journey together to address these health disparities that have been so persistent and pervasive, it really is all hands on deck. And that's right, the resources have to come from many different directions, but we have to maybe always be even more creative earlier in some of the settings that have limited resources. All right, so, we're back to COVID and the realities of COVID-19, right? So one question, and then we'll open it up. And maybe we also rapid fire this across each of you. But things that have been unique within COVID-19. So I know a lot of the issues that we've talked about have really predated even COVID, right? A lot of the things we talked about, and then trying to conduct research through a global pandemic. This is one example. We face many public health threats for all of us. I know we also face the realities of climate change in our work. And so is there anything that you found unique? I'll let anybody who wants to start us off for that, but anything you found unique working in COVID-19 around community engagement in this context?
I have to answer because I've been buffeted by COVID-19. So we were actually in the middle of about 3 different projects. None of them had anything to do with COVID-19. But the biggest challenges that we had were even finding ways to engage community. And I think one of the big lessons that we've learned is that the personal touch, as much as you'd like to think around flyers and communication techniques, once there's absence of that personal touch, it does make a very big difference. So even trying to engage a patient for a questionnaire on a telephone, to have them go online, to do virtual focus groups, those were all very interesting learning experiences. I think it's made us better, but I'm not sure if it was as effective as some of the traditional strategies. But it does highlight the need for us to continue to at least engage on a personal level, despite all the other things. We can build on technology and so on later, but that personal touch is very important. And then I did like the other point that was made about how relationships change over time. And I think continuing to do research is also very important. When communities have not been engaged in research, it's also very hard to go back to them and try and engage them again. And I think that's an important point. Even despite some of these challenges, we must still keep trying, because when we drop the ball for too long, it's harder to pick it up. Yeah.
Thank you. Anything to add? Yes, COVID. Please, Dr.
In our case, in fact, COVID represented an opportunity. Those patients were forced not to go to health facilities because of the very big demand by COVID. So we were able to organize outside the hospitals, near the communities, meetings and other ways to interact with the community, to elect peer supporters within the community who would come to get their medicines. So for non-communicable diseases in these low income settings, COVID was also a way to show the link between both communicable and non-communicable diseases, and in fact has given us some sort of power and position now to start advocating and negotiating with governments and with other institutions that are leaders or policymakers in changing the way non-communicable diseases, and particular cardiovascular diseases, are seen. So I think that this is one of the lessons that I wanted to highlight from a very low income setting such as Mozambique.
Thank you.
Let me just quickly add very briefly, and I agree with everything that's been said, but in India, we also had, two different sets of fairly significant lockdowns where there was virtually nothing which was possible. You couldn't go out, and therefore we were compelled to come up with strategies for continuous engagement with the community so that they didn't feel as if we jettisoned them in the time when they possibly needed us most. Number one, trying to get different ways of providing care and providing medication, because hospitals had been converted into purely COVID treating entities. So I think it became the whole way of distant care delivery using telemedicine, and using research piggybacked on that vehicle became a very important learning experience for us. It's clearly not a great plan A, but I think it did help us develop a reasonable plan B.
Oh, I like it. I get from each one of you, what I take away so valuable here is how essential it is to, in this moment, expand our toolkit, right? Not to replace, right, but to really extend and think about this as sort of the lessons we can learn, and harnessing those innovations as we can. So I really very much appreciate that. I know Dr. Williams is on standby to help us and moderate us with any Q&A that's come in from the folks who have joined us in this conversation. Today, we want to really honor everyone's perspective and voice here too. So I'll turn it over to you, Dr. Williams. If there are any questions for the panelists, I always have questions for the panelists. So we will not have any downtime. Don't rest, my friends. I have more questions for you, and I think our colleagues do as well. Dr. Williams.
I agree, and I always have questions too. So one of the questions in the Q&A box from Stanley Zeffler, for the panelists, what do you feel has been your greatest accomplishment in your community work? So I'm going to start with Marshall. What do you think, Marshall?
I was just typing a question. I got a question instead. I don't know if I can say there's any sort of major accomplishment. I think any accomplishment I talk about would be kind of how I perceive myself. So I think one of the big things that work in the community should do is to change your mindset, to kind of make you deprioritize yourself and not be afraid to look stupid or to, do other things that you're not just playing one role, the serious scientist or the doctor, but just to be unafraid to embed yourself. And I think that's something I've learned from working with a number of colleagues, not necessarily physicians, but clinicians, nurses, other persons who kind of put themselves a little bit more out there, and you really do see that reward coming back. So I think that would be a lesson that I would have learned, and that accomplishment to kind of be less concerned about self. That really does make a big difference.
Yeah, great. Nikhil, what about you?
I think for me, personally, the journey from looking after a solitary patient and then trying to convert that learning incrementally to develop systems of care which are going to affect communities and the way we deliver community care in health systems. I mean, that journey has been most fulfilling. Whether that's an achievement or not, I think time will tell. But as an experience, I think this has been very gratifying to me because, sitting in a clinic, you're dealing with one individual at a time. the learnings from that entire escalation to extreme right of the translational journey has been, I think, a very important part of my whole experience. And as I said, something I cherish.
Yeah. Thank you for that. Anna?
Thank you. So for me, I think that most important was to really become very humble and learn from the community, because from being these many years working with them, trying to think that I have a question and I have a method and I'm in charge. In fact, we learn to understand the community as they become our partners. They start talking to us and we learn a lot from them. And we become humble, extremely humble. And I think that the second one is that there is really no barrier to do research, even with communities that apparently do not understand very well what we are doing. I've been doing genetic studies in the community, very complex studies with machines that they don't understand, portable ultrasounds and things like that. And I think that that lesson is a lesson of extreme altruism from these communities, which are sometimes very impoverished, but they feel that they have something to give to others and to give to the world when we are talking about global health. Those would be my two takes on that.
Thank you for that. And Marcella?
Oh, goodness. I'm just nodding in agreement. I feel so much gratitude, and I hear that from all of my colleagues here today too. I just have immense gratitude to be on the walk and on the journey with the community partners. It is just the most rewarding, right, work ever. And I think something that we, in the different tables I'm at, we work so hard to do, and it's always that work in progress. The dynamism of this is going to stick with me, but that power shift, right, to really get to that point of maturity where community is leading and we are there in service, right? And so I think every time, the closer we get to that, I feel like that's the greatest accomplishment when I'm showing up in service and at the request of a community expert. That's my position.
Yes. And I agree that the person who asked the question, I agree with him. Excellent reflections on that. I have another question from the Q&A, and I'll just read it. When we talk about global health, the research itself can be local. Like many of you, doing global health studies, but being the executing researcher locally, how do you navigate the possible disconnect between what you do and the researchers from abroad who have best intentions, but try to do research not knowing local realities? With that question, I'll start with Nikhil for his thoughts.
Thanks, Makita. So if you think of the concept of global health research, I think the construct, at least was initiated within a developed country context, right? It never started with a low and middle income country researcher coming up with a research question, generating the funding, packing his or her bags and going to a developed country to do the work. So, I mean, I think the first thing to understand is that it started in the other way around, that a developed country researcher thought of something, came up with the money, and decided that it may be good to also work in an area beyond that. And therefore, it is important that the person who comes in perhaps with both financial and academic heft has significant discussions with the local investigator, that is a low and middle income country investigator, because they may come with what they feel is a genuine question, but maybe an absolutely irrelevant question in the context that they want to sort of address that. And I think I've been particularly fortunate that, the people I've worked with have been exceptionally accommodating, understanding, willing to participate in a dialogue, listen to my rants on occasion, and also accept that, it's not a one-way street in terms of conversation. It has to be a bidirectional conversation. It has to be discussed based on what is available as evidence. I think the emotional overlay has to be thrown right out of the window, and both sides have to have the grace, humility, and maturity to accept when perhaps their point of view may not be the most appropriate point of view. And I think that has really been very, very useful. And so I've, in the sense Makita, you possibly know that I collaborate a lot with people at Emory in Atlanta, and we actually did a webinar called it Decolonizing Global Health Research, right? And essentially trying to put through this exact perspective that, equity and equality between investigators would be required for a successful delivery of that project, but perhaps even more importantly, a sustained relationship, which is what really would give rise to, many, many years of togetherness and good quality work.
Yeah. Marcella?
I completely agree. And I think, we've heard, Dr. Mukumbi said it, sort of some of the north-south dynamics that are at play, but how exactly decolonize, disrupt, and how do you sustain those partnerships, whether it's community engagement or the sort of whiplash that can happen in the research world with maybe short project periods. And we've talked a lot about all of the work that has to happen in establishing all the relationships. I think really critically in establishing some of this almost contractual understanding of the ways in which the partnerships will occur. All of that takes a lot of time. And I think a lot of some of the issues we have to deal with are the time pressures that maybe cause the circumvention, right, of these important discussions and community partnerships, but also investigator to investigator partnerships. So I'm really grateful to whoever raised this question. It's a fundamental one.
Yeah. Marshall?
Yes, actually, it was a very important point, because I think the other thing that you also want communities to feel is that communities like to feel that there's some local input in research that's being done. And I think one of the worst things is when they believe that it's like a payoff for the investigator. So in other words, you're getting all the reward and the glory, and somebody has just thrown this into your lap. So it's very important for that sort of, because if you create that environment, then it often creates one of the biggest barriers you can have to engage and recruit, when people don't believe that they believe you're just a puppet and not necessarily a part of something, that you've brought their needs and local concerns into account, and you're establishing and advocating for them in your own way when you're actually carrying out this kind of work. So that's a very, very, very important point.
And we'll end with you, Anna.
Thank you. I will just repeat what I said at the beginning. I think that we have the responsibilities. And one of the responsibilities that we have as local researchers is towards our community, like Marshall was saying. So preparing properly, then feedback to the communities after the work, during the work, as soon as some questions or queries arise, is extremely important. And I think that is something that we should do. And I think that when we are in a partnership and we are true partners, everything can be sorted out. But we really have to get this feedback from the communities and pass it on our collaborators.
Thank you so much. And with that, we're at time. I'm going to turn it over to our chair to close the session out.
Oh, thank you so much, Dr. Williams. I just want to say, thank you. This was a conversation I enjoyed so much. I know I learned a lot being here, and it's so important how we're showing up and the questions that we're asking and continue to ask ourselves and keeping this at the forefront. So hopefully others who have joined us today also were able to derive not just the knowledge, but actually the inspiration too from each one of you and the work that you're lifting and stewarding, and the what and the how of it all is really tremendous. So thank you once again to all of the panelists, and of course to NIH and NHLBI. Thank you.
Thank you.
And thank you so much. Thank you so much, Dr. Nunez-Smith, for chairing our great session. Thank you so much to the panelists for an insightful and thought-provoking session and discussion, and most importantly, your commitment to global health and community-engaged research. We really appreciate it. I'll now turn it over to Dr. Ilias.
Thanks, Dr. Williams, for moderating, Dr. Nunes-Smith for chairing, and for these amazing panelists, Dr. Talakri, Dr. Mukumbi, and Dr. Tandon for joining. And I know, Dr. Tandon, this is not the best time zone for you, but thank you so much for being so engaged and so great at participating in our panel discussion. Every single panel has been blowing our minds, and we feel just like you do, Dr. Nunes-Smith, where we are taking such mad notes and highlighting things. So hopefully there's going to be a lot that we can sort of process from these conversations. But thank you again. We are at break now, so we will be going for lunch break now till 1:30, and we will be coming back for session 5, which is data science and community engagement efforts, past, present, and future. So please join us again in 30 minutes after lunch break for our next session. And thanks, everyone. Welcome back to our day 2 of Advancing the Science of Community Engaged Health Disparities workshop. We're going to start with our 5th session of the workshop and the 2nd session for today, which is the Data Science and Community Engagement Efforts, Past, Present, and Future. We have an excellent panel here today, and I will hand it off to my colleague, Dr. Amir Katipo, who is a program director at the Center for Translation Research and Implementation Science at the National Heart, Lung, and Blood Institute. Dr. Katipov will be the moderator for this session. Amir, floor is yours.
Thank you, Maliha. Hello, everybody. I'm Amir Khatipov. I'm a data science program officer at the Center for Translational Research and Implementation Science here at NHLBI. I am pleased to cordially invite you all to this session entitled Data Science and Community Engagement Efforts, Past, Present, and the Future. We had such exciting 2 days already, and I've noticed that all the panels and all the presenters were stressing the importance of data science and community engaged research for health disparities. And we have actually 3 panelists today, and I will explain why. We had Dr. Philip Bourne originally assigned to chair the session, but unfortunately, due to the tragic events you've heard about in the news at the University of Virginia campus, he wasn't able to join, and Dr. Irene Danko-Mullen was able to step in the role of a chair for this session today. I'd like to introduce our, and also we had Olga Brajnik, our own Olga Brajnik from NHLBI, to step in as an additional as a panelist for the session, and we're very grateful for her to be able to do it on such a last-minute request. I will introduce our chair today, Dr. Irene Danko-Mullen, who is a national recognized industry physician, scientist, and thought leader and health equity scholar with over 20 years of diverse regional and national leadership experience in primary care healthcare systems, business, and the community. She is the Chief Health Equity Officer and Deputy Chief of Health Officer at Meritive, which has formerly been known as IBM Watson Health. We also have Dr. Ali Magdad, who is the professor of health metrics sciences at the Institute for Health Metrics and Evaluation, and the Chief Strategy Officer for Population Health at the University of Washington. Prior to his involvement in his current activities, Dr. Magdad worked at the CDC. And he is a well-known researcher and well-published, and he published groundbreaking research on local level disease trends and leading risk factors for poor health. And his work on obesity is among the most highly cited in the field. Last but not least, Olga Brajnik is a data scientist, program officer at NHLBI, and where she synergizes science activities across NHLBI and co-leads Biodata Catalyst team. Olga facilitates the adoption of innovative approaches in biomedical computing and informatics, collaborative technologies and data and knowledge integration and different aspects of modeling and visualization, and she led a variety of interagency initiatives in open science and innovation. We will have 3 questions posed to the panelists today. Because of the name of the session, that is deals with past, present, and future, we will have the first question on what are the challenges in data science, specifically in the community engaged health disparities research. The second question will be what are the opportunities that our experts see exist in empowering the community engaged health disparities research. And then as the third question, we will address the what is on the horizon for the data science as we see in the near future, in the 3 to 5 year perspective, and for the remote perspective of 5 to 10 years and even further. So with that, I'd like to welcome Dr. Irene Dankel-Mullen. And Irene, please take it away.
Thank you so much, Dr. Kasipov. This is, first of all, I'd actually like to applaud the NHLBI and the conference organizers for pulling together this very important topic and including the role and relevance of data science in advancing community engaged health disparities research. So I'm really honored to have the opportunity to add to the ongoing conversations from the various experts and thought leaders that have been invited to be part of this panel, and really want to acknowledge the incredible yet challenging work that has been done in advancing the science of community engaged research. I think these are efforts that have established an important foundation that has allowed us to build on efforts in data science. And so, as you mentioned, our topic is going to look at aspects of data science and community engaged research, challenges, opportunities, and recommendation. But I do want to provide some context for the definition of data science. And we know that data science is generally the study of data and methods used to learn from data. But we know now that the healthcare ecosystem or the health ecosystem has generated large amounts of data. This has been driven by all the vast amount of biomedical research data, public health data sets, hospital data, social determinants of health, and community engaged health data. They are all meaningful, but we know that they're siloed. And we know that they can provide meaningful insights and advance the science because all these data points are relevant and they're critical. But they're in such massive amounts to become, and so complex to be handled by traditional statistical analysis. So we're here basically talking about the need for, we're talking about the advanced analytics or artificial intelligence, machine learning methods that are being used or leveraged to solve these complex challenges, improving health and health outcomes, and especially for patients or populations that are experiencing social disadvantage or adverse outcomes. And so like in the larger domain, our role as data scientists, as researchers, especially working at this intersection of data, is to explore how data, right, whether it's from clinical trials, whether it's from real world evidence data sets, how it's being interpreted as scientific evidence. We want to especially discern how our data that's gathered from the vast amount of important diverse research, from the community consultation to community engagement to community-based participatory research, is being translated into scientific evidence. Not only how it's interpreted as scientific evidence, but also how it impacts ongoing science, how it impacts society and policies, and especially allocation of resources for health. in data science, we want to know how the data, because we know it's increasingly being recognized as a public good, how the data is being captured, how it's being encoded in our technologies or tools for insights, how it's being designed and implemented, because there are different data structures that encode different information, but it's also about whether we have the right data architecture for community-based participatory research or community-engaged research. We also want to explore, data science explores how our AI and machine learning methods, our forecasting algorithms, our risk stratification, how they rely heavily on comprehensive and relevant data. And finally, as data science, we look at how we're establishing ethical standards, how we're governing the collection, the design, the management, the use and sharing of data and data-driven technologies to improve health outcomes for everyone and for social good. So a little bit of context in sort of the categories, right? Scientific evidence, the structure of and the data architecture, how we're exploring it as a public good, and how we're looking at our predictive models and also ensuring ethical standards. And so I want to pose, these are all three discussion, we're going to cover these three discussion topics that are aligned with the past, the current, and the future. And we're going to start with the challenges for data science. So, and so I will start with Dr. Motka, that in terms of what are some of the challenges for data science and community engaged health disparities research. And then we'll turn it over to Dr. Brasley.
Thank you, and please call me Ali. I'd like to step back a little bit. What you said, the introduction was really very important and interesting to frame the topic. I work in global health, and here, even in the United States, and I've seen it in many places where data is being collected on a piece of paper. And a donor with good intention will come to that place and say, we want to make it electronic and then send it faster to the Ministry of Health. But there is no attention paid to what's being collected. If you have a system that's currently right now, however it is, paper or electronic, and it's not capturing the right data, making it electronic is not going to solve the problem. If you have a system right now and you don't put in place people to analyze that data on a routine basis and feed back the community for action, making it electronic is not going to help. So when you come to the challenges, and let's be US specific, and by the way, I agree with you, I'm really pleased and happy that NIH is investing in community health through several programs that I'm aware of. We in academia who get funding from NIH was only disease specific or risk factor. So I'm really pleased to see a lot of activities at NIH to work with communities and focus on communities. So when we come back to what we really want to talk right now in the US, many of the data elements that we need to make community-based interventions are missing. I should use some general examples. We're struggling right now in one of our projects to break down, for example, Asian and Pacific Islander. The data is collected as Asian and Pacific Islander. And there are at the two spectrum of health, life expectancy or mortality, etc. Asian do the best here, Pacific Islander not so much. We don't have much data about Native Americans, Alaska Indians. There is no survey right now to understand the problems that they are facing. And many communities, small communities that are disadvantaged, many of the surveys that we have right now don't capture what they have. And we in the US say we want to do community engagement. So the first step, to answer your question, would be we need first is to analyze the data that we have right now, maximize its utility. But we need a roadmap to say what data we need to collect in order to improve community health at the local community and how we should do it. And is it passive or active data collection? Remember, many of these communities, there is so much data going on. We know what they buy, we know where they go, we know how they move, There are a lot of data systems here that we can work with. But I will answer your question briefly in the United States and say the lack of data right now is impeding our ability to help communities at that level. Over.
Thank you very much, Ali. Olga, you have anything to add to
the
challenges?
Absolutely. Thank you.
Yes.
Thank you so much, Irene. Can you hear me okay?
We can hear you.
Fantastic.
Perfect.
Okay, great. This is such a great panel. I already love what you both said. And I want to add something that I didn't put in my bio. For the last 2 years before joining NHLBI, I actually worked mostly in community engagement with the CTSA program, which is the largest investment from NIH into clinical research. So all these topics about community engagement and data science are really close to my heart. So first of all, it's obvious that our entire planet is going through digital transformation. Most people have cell phones. That makes collecting data on individuals and communities very easy. So we have a challenge here of not collecting data that we can collect in abundance. But the biggest challenge is in data literacy. If you look at social media such as Facebook, LinkedIn, Instagram, and so on, people are sharing their private information very easily. And it's not so easy when you come to biomedical domain. Here is probably a paradigm that we need to either change or bring up the data literacy and digital literacy in the entire community and the entire world. Another thing, of course, here is like the consent that we are now signing without reading it. I remember I read a joke about it that a young couple signed off on their firstborn when they were signing a cell phone agreement or something like this. Of course, it was a joke. It was just a test, how difficult it is to read through the agreements. And this practice of fine print is kind of the topping on the cake. How many people read the entire document before signing it? So we have to really speak the language of the people who we're talking to and who we want to collect the data from, so they understand the consequences of the signing documents. The second challenge that I think is very big here, of course, according to NIH, communities that experience health disparities, especially hard, include racial and ethnic minority groups, people with lower socioeconomic status, underserved rural communities, and sexual and gender minority groups. So first of all, these communities, most of them have very low literacy, digital literacy and data literacy that I was talking about. So they have a much higher level of being taken advantage of by researchers that don't mean any harm. They just working on building their careers and collecting data for research and publications. But then they kind of take this data, take it somewhere, don't bring it back, and these individuals don't benefit at all from participation, except that their data could be exposed somewhere. So I really like this phrase that the biggest challenge in every relationship is to understand that the other person is real. So we really have to respect each other and respect each other's goals. The goal of researchers is not bad, but they have to be respectful to the values of the community. One challenge that I put here is kind of, I would love to have a discussion with Ali on this. We keep collecting data on everything. Our data grows enormously every day. And as a long-time program officer at NIH, I have been hearing this for years. We need more data, and thus we need more funding. We need more funding to store data, to curate data, and it is all true. But my question is that maybe, just maybe, instead of collecting more data, we need a better learning system. A learning system that will make us aware of what kind of data we need and what is our goal in the end. So the system that will help us to adapt to changes, that will help us to evolve with the world around us. And so the question is not so much about data per se, but about learning from data. And I'll stop here. I have a bunch of other things, but we can come later.
No, that's terrific.
Irene, thanks. Can I say something very quick? I mean, I love what you just said, but we definitely, I mean, we're all saying the same thing in a way. We definitely need to make sure that we can connect all the data that has been collected right now and then maximize its utility and using it. But the key issue, we want that data to speak to policy. So what? At the end of the day, it has to lead to action. Then automatically when you say, I want data to lead to action in the community, then you want to involve the community and you want to involve the policymaker in that community or the people in charge in that community, because it's a circle. They need to tell you what to collect and you need to give them the data to act on it, because sometimes their priority and the issues that they can fix different than what we look at that community and say that's the problem. So you could go to a community and do your good job and say, well, obesity is number one here of a problem, and let's talk to you about obesity. And the community would say, no, I don't want to do obesity. I want to talk about something else. And then you need that ability for you as a data collector, or you're analyzing the data, to feed into what the community needs in terms of policy that they feel they can act upon immediately as they can. That's one. The second one, for communities to own the data and act on it, they have to own it. And the only way to own it, they have to be involved in the analysis. So building that capacity to be able to look at the data and analyze it, or make it in a way that is a visualization. You don't have to be a genius in statistics, but I can put it for you like what we do at IHME. You can drill on the data and look at it and play with it. These are very important for us to get the community involved. Over.
Yeah, I think you both have raised really, really important issues around the several challenges, right? And for data science and community engaged research. You talked about standards for race and ethnicity, data literacy, digital literacy as well. But I should also say that data science at its core, it should be an interdisciplinary field, right? Just like community engaged health disparities research is grounded in the vision to improve health and outcomes for all populations, and especially socially disadvantaged, those experiencing social disadvantage. The data science agenda should also be able to generate meaningful scientific evidence, enhance scientific accuracy, also with the goal for achieving optimal health and outcomes for all. I think the challenge is that these two research fields have not realized the potential synergies of coming together, and maybe because of lack of expertise or awareness. But I would say that community engaged research has focused on building, nurturing trust with communities. Ali, you mentioned that. Developing a co-learning process, right, of engagement between the researchers and the community. And they've centered or emphasized, community, social cohesion, social capital, social well-being. And this is where data science should be incentivized to do, should be incentivized to align with community engaged research to realize their full potential. And so, for example, with the questions in data science, they should prioritize research questions that matter to the community. And the challenge is that it's not being done yet to the full potential. They should be engaged in helping to, in engaging the community across all the domains or disciplines of data science. I think that's one of the challenges that has not been done, and that's why we're sort of in the state that we are. So really, community engaged research should intersect across all the domains of data science. And maybe I think this leads into, we're talking about challenges, but it's also important to talk about the opportunities. And Ali, you had mentioned it, a larger and important challenge for community engaged research and data science is resolving issues around data ownership, responsible data sharing, right? Because both scientific endeavors are grounded in efforts to improve health, to promote equity, and to improve well-being. But when you ask both disciplines around data sharing, for example, or how data is controlled, who is accountable for the data, or who is entrusted to promote responsible data, they may be answered differently, right? For community engaged research, the data will largely belong to the community, and it's accepted as community-owned asset, because for the most part, it's the community that provides the data to enhance scientific research. There's power sharing, and the research teams are entrusted to promote responsible data sharing. And the data science community, on the other hand, has a goal to democratize data, right? Democratize data and make it transparent, and transfer the data from the community to the society. I mean, it's all for global and secondary use and benefit for everyone. But I think in the method of this transferring it and generating huge data assets, there may be some missed opportunity where to think about, okay, let's go back and realize that what we're doing here also needs to go back and benefit the community, right? So we may look at biases in the data. We may look at ethical and legal implications, but it also turns out like the two disciplines need to align on data sharing and data ownership. But I want to just go to the next, because there's so much to say in challenges, but perhaps let's align the challenges with opportunities for data science in empowering community engaged research. So I could start with Ali, then Olga.
The best thing to do here is to involve the policymakers from the community and the community early on in the data collection and look at what we have learned from COVID-19. Forget the data problem. For a long time, couldn't report by race, ethnicity, diseases, mortality. But even when the vaccine came, when we had a very good vaccine, we should have involved the community early on in order to accept the vaccine. And many of us got involved with their own community to talk to them and get the vaccine. But you need to involve the policymaker, the leader of that community early on in order to make sure they understand what you are doing, why you are doing it, and what's the outcome here. And it's very important for all of us when we go to a community, we work together on what's the problem, why the solution, and what success means. And the community will get very much engaged. I could give you a very simple example. During COVID-19, there was a lot of rumors about the vaccine in my part of the world, in the Arab world. And I'm originally from Lebanon. Everybody in Lebanon, my family, know that we have one daughter, only one daughter. And everybody will ask me about the vaccine. All what I had to say, my daughter took the vaccine. So that lesson is very important for us as we are scientists or whatever we do in data, to show up to the community every now and then. It will be ideal if that person who's showing is part of that community. So we need to train people from that community on the long run. But the white robes need to come to the community. We need to roll our sleeve and need to come and show them what we are doing, why we are doing it. And yes, my daughter got the vaccine. So I'm not asking you to do something that I didn't do myself or my daughter did. And that's very important for us in order to do that. So workforce development at the community level, clear communication early on with the community and involving the community early on with what you are doing. Then the data will guide you to a decision and a policy that you work together with the community about, and the community owns that. It's a community decision. It's a community participation here, and that's what grants success. over.
Well said. Yes, any Olga, any opportunities to build on? So some of the opportunities exist, for data science and community engaged health disparities research.
Yes, I totally agree with Ali. Influence and policy is a big change. Let's talk about like data sharing. We cannot even collect data on stigmatized communities. We cannot even collect very simple things like geolocation because people are afraid of hate crimes, abortion now. So all information about all data about people somehow connected with this is impossible to get. We don't want to get it because if somebody else gets to this information and uses it for the wrong purpose, then we all will be in trouble. So it's very much connected with the entire societal values, entire set of societal values and policy. So trust has been mentioned in this workshop, and we've been talking about it for a long time by now. I think building trust is very important. We have to build systems and processes that we and the community trust. There is now a development of trustworthy AI principles, and HHS has created a trustworthy AI playbook that identifies key components of trustworthy AI and ML in the context of healthcare. So this includes models being fair and impartial, transparent and explainable, responsible and accountable, safe and secure, robust and reliable, and privacy preserving. The principles are great. How we implement it, as you know, devil is always in the detail. The implementation is, of course, difficult, but again, we have to try to build these models properly and make sure that what we get from AI, from the applications of AI, we can trust in the end. A lot of people don't trust machine learning and artificial intelligence because it's a black box. We don't know what's going on inside. And with the approaches of computational approaches take into consideration community values or individual values for this matter. We all come from different cultural backgrounds, and in some cultures, many things are not appropriate even to ask. Like you cannot ask women from certain countries if they are pregnant. It's totally prohibited. You cannot do that. And we have to be respectful, and we have to build our models based on the community values. So in general, I much prefer to talk about health equity than health disparity, because this is our goal. And the disparity is what we have right now. But just like Ali said, we don't get the right data when we kind of focus on disparity. We have, like, I apologize, you gave the example about communities, like ancestry, like you cannot, you're asking a question, but it doesn't provide you a real answer because you cannot separate these two different races. So the other opportunity, I think, is enormous, is focus on well-being and resilience. NIH historically been focused on diseases, kind of ignored this opportunity until now, until recently, not now, but until recently. And I think now it provides a huge opportunity. For example, nhlbi added resilience in its strategic vision. But how do we bring focus to well-being? Can we even define health? What data do we need to provide people with assurance or correction of their life path. What well-being markers should we focus on? And can we even describe what healthy human being, healthy and thriving human being look like? Maybe it's not only about blood pressure, but about mental focus and about mental goals. And more than that, it's about realization, full potential that a person brings to this planet. So I'm happy to see, continuing on opportunities, a lot of collaborations among different agencies. During the pandemic, many agencies realized that our communities, many of our communities were not resilient enough. So the Equitable Long-Term Recovery and Resilience Initiative brought together more than 35 federal agencies to bring together different assets, map different assets that are not focused on social determinants of health, but they are focused on vital conditions. So it's like when you think about lack of something, that's social determinants of health. And when you think about abundance of something, you think about this vital conditions. And this federal plan is being developed, and a lot of people from senior representatives from these federal agencies are working together on defining what resilience is and how we can approach it. I think this provides enormous opportunity for data collection by other agencies and bring it together for the research purposes. I'll stop here. Thank you very much.
Irene, I will not forget myself if I don't say something quick about, you want to empower the community, you need to spend time on implementation, translation and implementation. This is very important to do it. And again, I'm so happy to see that NIH is investing in translation, implementation and translation. And let's be realistic. I mean, Amir introduced me and said, I work on obesity. If you come right now to a community and say, without knowing the particularity of that community and what will work in that community in terms of implementation and transition, your recommendation will be have a healthy diet, fresh fruits and vegetables. But it's a food desert. 7 p.m., a woman wants to feed her family. The only way to do it is the corner, buying hot dog rather than getting in a bus and going for a long distance to buy more expensive fruits and vegetables. Exercise. Well, there is no place where I can safely, I don't mean time, safely cross the road and walk in order to exercise. And unless you understand that in a community, your recommendation for implementation and translation is going to fail. And it's very important for us, in order to empower that community, for us to understand the issues that our community is facing. And our solution cannot be overall, can be for every county, for every neighborhood in the county, to have the same solution or the same translation or the same implementation. It has to take into account the deck of cards that they are dealt. And we, sitting in our offices here, are not going to get it unless we go down on the ground and work with that community and talk to them and understand from them what are the issues.
No, absolutely. I mean, I think you both have talked about great opportunities that exist. Examples being policies, implementing policies that govern ethical, responsible AI, looking at, collecting data that focuses on well-being and resilience of communities. And so what you're talking about, the opportunities are for translational, bidirectional data science that is closely intertwined with community engaged research, right? I think data science has a lot to learn from frameworks that have been developed in successful community engaged health disparities research, and be intentional in efforts to center health equity, to promote justice, social justice, to integrate this co-learning processes between data scientists and community researchers. And recognize, I think in community engaged research, a lot of the researchers recognize that cultural awareness, the preferences, the values, the conscious or unconscious biases that exist in healthcare and integrate into the data. And I think this is where there's a lot of missing data capturing the experience of the community, the values and preferences of the community. And there's a huge opportunity for that, right, in data science to really be aligned, and a huge opportunity for workforce development and diversity and addressing disparities. Well, let's maybe go into our last final question here or discussion around the horizon for data science and community engaged research. What do you think should be your proposed, well, you could talk about either the future of data science, right, for community engaged research, or you could share maybe one or two strategies you feel it's particularly important to think about to make sure that we are addressing it to advance the science of community engaged research and data science. And so I want to, because I know that NHLBI wants to come up with some opportunities or research questions to build on this, making sure that we're talking about how we can really build on data science methods or integrate CER or community engaged and data science. So I could start with Olga and then Ali, and then I can wrap up.
All right, thank you, Erin. There are so many opportunities and dreaming about the future. I'll bring my favorite example. Maybe it's a little bit dated, but working with data and evidence, for me, the best image of it comes from Steven Spielberg's Minority Report, where Tom Cruise moves pieces of evidence on the screen and then plays it out how they fit together. So that's how I see the healthcare and maybe research of the future. Let's say we have a reference genome and exposome, and we plug in our data. So we are in charge, we are the owners of the data, and we are the creators of our life and our health. We can set our values, run the simulation, and see both long and short and long-term outcomes. We also could see the impact that our decision right now about our future and health, how it impacts our loved ones, community, society, and the whole world. We can accept or reject it and rerun the experiment until we come to the result that we really want. We can also reverse engineer the final goal into our current well-being. The challenge with the second approach is that we rarely really know what we want. For some reason, very, very human, more than data science, a lot of things are taken for granted. And when we imagine the future, we think we'll have everything that we have right now, plus, but forget to mention what we really enjoy and grateful for in our current state. So that's one example for the future. Of course, technology that helps us to enjoy our life fully till our very end, that prevents our falls, that suggests interventions, connects us to the professionals when needed, comforts us when we need a hug, and so on. I'm talking about like home robotics and artificial intelligence, the systems that collect data, don't misuse it, but preserve our privacy so the bulk of the people with bad intentions don't enter our house. So robots that know our likes and habits and that can gently train us to adopt healthy behaviors. That was my second, and I don't know if it is 2 years away or 10 years, but I really hope to be comforted by the environment like this. The third, and also it applies to data science, but it applies to all our research, asking powerful questions. The tragedies that just happened at UVA and many other tragedies that have happened across the country and the world, how do we prevent them from happening? Not at the level of security surveillance, but way, way, way before it. Like, how could we look deeper in the structure and beliefs of our society? What values may eliminate the idea of hating or harming another human being? Maybe we can use some principal component analysis on a societal or global scale to identify a collection of factors that we need to correct in order to live happily ever after. That's all from me. Thank you very much. Over.
Terrific. Thank you.
Thanks, Olga. So for the future, I also would like to make 3 points. One of them is better understanding at the local level the social determinant of health, what's really driving these health disparities. And that's the only way we can address them, and we have the right policy, program, and legislation to address them. So let me give you an example on these two before I go to the third one. I live in Seattle, a very rich county, Microsoft, Boeing, Amazon, Starbucks, Costco, you name it. And then when you look at the King County as a county, where Seattle is, life expectancy is way above the average of all counties in the United States. So it's not the top, but it's way up there. So we had a county health commissioner who came to me and said, Ali, you're hurting me. You're really hurting me by saying I'm much better than everybody else. I have a problem and I know where it is. And I want you to look deeper within the county. So we looked at the census tract. 18 years of life expectancy difference was in this city of, King County was in the city. Huge differences, diabetes higher. That led to policy that is specific to that community. And I'll give you one policy. Here, the city, the county, decided, for example, to encourage fresh fruits and vegetables. Some of the stores that in these communities can't afford to buy the fridge to display the fruits and vegetables. The community paid, the city paid for it in order for them on one condition, that you put fruits and vegetables here and sell. So that's an example where you have to go deep, understand the data, understand what's driving the bad performance, and then address it in something that really will help that community and the community can see it. And the third one, we in this country, we learned a hard lesson during COVID-19 that many counties were not able to analyze the data they got from COVID-19. They didn't have the manpower or the epidemiologist or the statistician or the programmer to do it. We need to train a new generation of professionals that they can inform public health and decision maker. And we need to make sure that we don't keep training the same people. We have to train people from the community. Right now, the University of Washington, we're looking into some projects where we bring people from communities through either a certificate or training and payment from us in order to pay for their education, hoping and conditioning, hopefully, that they go back to the community and work in that community. We need to think of such a program. I came to this country on a scholarship that if I get my education, I go back and work in Lebanon. There was a war and I was told you don't need to come, but you have to educate somebody else to keep it going on. We need to take such system that we can train somebody, give them free education. If they are from communities where we need to have people work on data and on policy and make sure we give them the ground. We have to pay them equally in order for them to make it appealing to go to that community. This has to be addressed in order to make a change in the future. Thank you.
Yes, thank you both. Definitely brought up great comments and suggestions. Certainly building a pipeline, totally agree. We need a new generation of researchers and the public. But I think I hear both of you, which I agree, talking about data science being transdisciplinary, right? And integrating with community engaged research, promoting data as a public good, and making sure that what we're doing benefits all society, and especially leveling the playing field for communities experiencing socially disadvantaged. I'm certainly very optimistic. I think we need to be innovative and push ourselves in the models we're building. But even before that, I think certainly thinking about building, just working with community, with the framework of community-based participatory research and building that trust and trustworthiness, and making sure that we're prioritizing research questions from the community in the data science space, right? Because a lot of the time, I think what we want to do is include community engaged researchers and the community and stakeholder participants as experts in the process, right? In the process of data algorithms being modeled, in collecting the appropriate data, in answering the desired questions. And I think, Ali, you brought it up, those inherent variations that exist in social determinants and the multiple determinants that shape health of different populations and subpopulations. Making sure that data science is able to help and identify the potential of and best chances of uncovering these relationships between predictors, between the response, between helping really advice on what's good health, right? What's the well-being? So I'm certainly pleased with your responses, and I think we definitely should continue with promoting and enhancing data science and community engaged research. So thank you for this. I think in terms of summarizing, a lot has been done, mentioned here, where maybe summarizing it back to even providing the context, right? Like how, as data scientists and in the data science space, really thinking about, I think we all agree that our scientific insights and evidence need to be advanced and enhanced because our evidence is poorly used, not to its maximum potential. Our population's community experience is not really captured in our data science efforts. And so looking at the domains of data, making sure that we're interpreting data, or looking at what scientific evidence and discerning how the data that's gathered from the diverse research, community-based research, and it's really used to inform the appropriate science and especially allocation of resources for health. Looking at how we can really align on data sharing methods and data ownership. It's all about responsible data science. It's all about really making sure that we're working with communities and community-based researchers on building a right data architecture, developing standards. We talked about policy as well that governs the collection and the management and implementation as well. And finally, how we're establishing ethical standards to govern sharing of this data and data-driven technologies to improve health outcomes for everyone. But building trust, I think is really a huge challenge and the key to advancing the science around community-engaged data science research is what I'll call it. Because I think the research that is conducted today, the insights, what we do today is going to be critically important because in the year 2024, 2025, the world is going to be building on, or our society is going to be building on the basic knowledge or the ideas or the innovation that we're implementing now and the discoveries that we come up with today. So thank you both for a wonderful discussion. And I think I'll hand it over to Amira since we need to
yes,
time for questions from the audience. Thank you.
Thank you so much, Irene. This was, you facilitated such an excellent session and you raised so many important topics. My quick role here, remaining here, is to try to assess what the audience was asking. We have a few questions in the Q&A box, and I will start by the question from Dr. Let me see. Yeah, okay, they move around here. From Dr. Claudia Parvanta. She originally addressed the question to Dr. Mogdat, but of course everybody, that all the panelists can answer that. The question is, do you have any suggestions for creating timelines with donor agencies to empower communities to analyze and visualize data in ways that are easier for them, for the communities? It takes time, and we always seem to be in a crisis. What are your thoughts?
Claudia, I hope you're doing well. Claudia and I, in full disclosure, work together at CDC. Yes, I totally agree. Right now, many donors, including the Bill and Melinda Gates Foundation, one of the requirements is you collect data, you have to release it. And I wish more people will say that. You have to release it, make the data, of course, protecting the identity, but make the data available, and you have to make it available so we maximize its utility for the community. And also many donors right now, even for some of our grants here at IHME, is to make it in a way that the visualization and make it in a way that somebody without the knowledge of statistics or epidemiology can dig into the data and get what he or she needs from that data in order to be used for policy. Yes, I would support, I mean, this is a great idea and a great question. I would support that donor will put that in as a condition. You collect your release and you make it available through a visualization that the community can use it and the community can benefit from it, even without knowing anything about data collection, epidemiology, and statistics. Over.
Thank you. And Dr. Mensah commented that, of course, NHLBI and NIH in general are very interested in this topic. So you are welcome, Dr. Parvanta, and others who are interested in contacting our program staff, and we will be happy to discuss this topic. We have also a question, a comment from Dr. Seffler, who mentioned that he agrees with Dr. Mogdad about the diverse perspectives and priorities that you commented about. We may come with a certain level of expertise, he says, that we think can offer to the community, but the community may have a higher priority that they want to focus on. So it can be difficult to develop a joint focus on one area. So I welcome you to address this question if you can.
I mean, I totally agree, but no, community will come with you in order to make a way to benefit that community. That's my experience. But I can give you an example. You're totally right. I was working in Ethiopia when I was at CDC, and we went to a place where we were doing a feeding program. And when we arrived in order to work with that community to evaluate and expand the program, there was an illness for the animals at that time, the cows. And all what they wanted to talk is, help us, the cows are dying. So I called the embassy at that time, and then we got a vet. And we said, okay, we're going to take care of that. And then the vet came, and then they worked with them on the problem. And then we went back and started talking about the health and what we need to do in terms of the feeding. So yes, you have sometimes to address the community needs within your capacity, of course. And the community at the end of the day will know that's a problem, that it's a priority for them, but the other one is still a problem. And they would rather get a help with a problem that's not their priority, if that's the only way to get help for the community, if that priority of theirs is not something in your hands yourself.
Irina, Olga, you have anything to add? Are we good?
Can you, well, maybe you could also, can you repeat that question again?
The question is about the needs and how they're being assessed by the, data users, essentially, right? And the priorities that are exist between the different communities.
How we're addressing the different needs, right?
No, sometimes you're going to a community with a funding for like a topic, but the community said, that's not my priority. I want something else. And the question was how you compromise that, because you may not agree. So and that's why I answered. Yes, sometimes I'm not a vet, but I called the embassy and said, send. So something we could deal of. But if we didn't have a vet at that time, the community would have listened to me about feeding the children, and I still was able to do it when we solved the issue. I mean, it was initiated solving the issue of the animals. But that's when you go to a community, that could happen. The funding that you have is to do smoking. The community says, I don't want to talk about smoking. I want to talk about something else. Maternal mortality is the important for us.
It's true. It happens. And, it's happened to me as well, where you are given, funding for a particular work and the community is not really interested and they have priorities. And I think this is where, as a community engaged researcher or data science, working in the community, this is about establishing a long-standing relationship with the community. I think we're not just going in there for one particular intervention. I think that this is where, there's discussion and compromise and a planning process that includes their priorities, but also providing them with the awareness saying, there is, this may also be something to think about. And I think that's the way to approach this as sort of a
Irene, before we move, Amir, I want to, sometimes I love the question, but the reverse happens sometimes. I gave an example. I was involved in this study at CDC, Wise Women, where we added cardiovascular screening to breast and cervical cancer screening for poor women. And I was the young epidemiology project officer in North Carolina. I go to, and I'm talking, at community and meeting with them, and I'm explaining, now we're going to add the screening, and then this will help you find blood pressure. This is a heart attack. And this lady sitting in the back was giving me this look, And at the end of when I spoke and I asked questions, she raised her hand. And of course, the way she was looking at me, I wanted her to. And she stood up and said, where were you 15 years ago? My husband died from a heart attack.
Yeah.
Well said, Ali. We need to move on, give room for another session. I see Dr. Mensah wants to make some remarks quickly. And just for everybody, we do have an interesting discussion going on in Q&A, but this is all recorded, and we will certainly take that into we will take that in, and it will be reflected in our report coming from this workshop. Dr. Mensah, please.
Amir, thank you. Because we've run out of time, I think I will not ask my question, but I have to say that this has been an absolute fantastic session. I think we're all very saddened by what happened at UVA and why Phil is not here. But if he was, he would have been extremely proud of you. This is great. So thank you very much. On that last issue, though, there's something important I should mention for the benefit of particularly those of you who may be interested in sending research applications and grants to NHLBI. We think there are multiple opportunities where investigators have important ideas that they want to test. Don't come to us for community engaged research for that. There are arrow ones that are investigator initiated. I think for community engaged research, where we really need your help for us to find the ways where leadership from NIH and NHLBI is necessary, we must always begin with the community needs assessment and build your research hypotheses and priorities on what the communities are that inform your research design. So hopefully, if you have the opportunity to add additional thoughts to the questions in there, please help us identify the best ways for us to really focus on this. But this has been fantastic. So thank you very much. It's really great seeing you all.
Thank you.
Thanks.
Thank you, Dr. Mensah. And
thank you.
Heartfelt thanks to Irene, Ali, and Olga. This was a wonderful discussion, and I'm letting Maliha to take it away.
Great.
And close the session.
Thank you, Dr. Katipov, Dr. Mokdad, Dr. Dankwa Mon, and Dr. Brajnik, especially for jumping in so late in the game and still carrying on a wonderful discussion. So we are going to go on a bit of a break. It's not a full 15 minutes, but that is fine. We request that everybody return by 2:45 as we will go into our last session, and then we will start closing down the program before we end around 4 o'clock. So our last session for the day is Advancing Inclusive Excellence in Community Engaged Research. As all of our panelists have been amazing and our sessions have been great, this one will be a great one. So last but not least, please join us for session 6 at 2:45. Again, thank you, Amir, and all the panelists for session 5. This was fabulous. Welcome, everyone, and thank you to all our attendees who have been sticking with us for the whole day and especially waited for this one session, which is probably one of the most important panel sessions we have, but because of the time we have it and later on in the afternoon, but we appreciate everyone who's here. This is going to be focused on advancing inclusive excellence in community engaged research. And for this session, I'd like to invite my colleague, Dr. Desiree Salazar, as the moderator. She is the Diversity, Equity, and Inclusion Coordinator for Extramural Programs at the National Heart, Lung, and Blood Institute. So Desiree, floor is yours.
Hey, welcome everybody. Thank you for joining us for this very exciting session. And please stick around. We will have some closing remarks after the session ends. But I'd like to introduce our chair of the center of the session, Dr. Monica Webb Hooper, who is the Deputy Director of the National Institute on Minority Health and Health Disparities, and our 3 esteemed panelists, Dr. Harolyn Belcher, who's the Vice President and Chief Diversity Officer, as well as Director of the Office for Health Equity, Inclusion, and Diversity, and Senior Director of the Center for Diversity in Public Health Leadership Training at the Kennedy Krieger Institute. Dr. Marie Plazame, who's a medical sociologist and Joint FXB Health and Human Rights Fellow, as well as NSF Postdoctoral Fellow at Harvard University, and Dr. Giselle Corby, who's the Keenan Distinguished Professor of Social Medicine, University of North Carolina School of Medicine Director and Director at the Center for Health Equity Research and Professor of Internal Medicine. So we're gonna Dr. Monica Webb Hooper will get us started, and then I will come back on in the last 10 to 15 or so minutes to take questions from the audience. I'm very much looking forward to this session.
Thank you. Well, good day, everyone. I am delighted and honored to be here with you and to have, the opportunity to share this important discussion and session. And we have such an esteemed group of panelists, so I'm just really delighted. The session of this the title of this session is Advancing Inclusive Excellence in Community Engaged Research. And inclusive excellence is a philosophical approach to higher education administration and processes that means that you attend both to the demographic diversity of faculty, students, research teams, which includes meaningful partnerships, and then the need to develop climates and cultures within institutions so that all have a chance to succeed. And during this panel, we're thinking about inclusive excellence in the context of community engaged research. And I think one of the ways that we advance inclusive excellence in this context is with cultures that establish and sustain scientific environments that really cultivate and benefit from the full range of talent. And NIH does aim to build a self-reinforcing community of scientists, increasing capacity through really shaping a critical mass of early career scientists who are committed to inclusive excellence in all domains of research, but particularly in community engaged health disparities science. And so in this conversation, we will be talking about this more and how we can facilitate inclusive excellence to train investigators in the community engaged research space, and doing that in responsible ways, in non-exploitative ways, and to balance and broaden the perspectives and just positively impact scientific discovery. So first, we'll turn over to Dr. Plazame to share highlights from her journey as a young scientist entering the space of health equity related research.
Thank you, Dr. Hooper. It's really great to be with you all this afternoon. I guess we just wanted to start off our session by highlighting my own, early career path and how I got to where I am today. And so I originally got my bachelor's from the University of Rochester in public health. I was initially pre-med and really interested in helping patients, but fell in love with public health after I took a Public Health 101 course. And from there, I got my master's in public health at Drexel University in Philadelphia. At that point, after I graduated, I wasn't sure what I wanted to do, but I started working at a cancer institute and realized that I wanted to be part of the research team. I wanted to ask questions that involved exploring how race and racism impact health. And so I decided to pursue a PhD in medical sociology at Howard University in DC. And it's from there, I really took advantage of all the opportunities that are available at Howard and in DC. And I was able to connect with really great mentors and able to apply to different programs, and eventually started a postdoc here at Harvard, where I'm broadly examining how race and racism impact the clinical provider relationship and how that does reproduce health disparities.
Thank you so much for sharing that. It's great to hear a little bit about your journey, and hopefully as we get through this conversation, you'll be able to infuse more, because I think it's a important journey that others can benefit from, from your experience. So let's move into the conversation. As I said earlier, most of what we're going to focus on is early career scientists and how we can advance their careers in this space. And before we delve into that, I'd like to start with thoughts and advice that the panelists have for established investigators or mid-career investigators who are seeking to apply community-engaged research methods into their work, who may be newer to this approach to conducting science, including those who work in, basic clinical sciences, data sciences, including, I would say I would count genetics and genomics. And, they may have trainees in their labs, or they're mentoring early career scientists. So I'd like to hear your thoughts about, starting there, and then we'll move into more of the what's happening in the early career space. But there are people who are training early career scientists, and we want to make sure that we hear from you about your thoughts on how they can do that. Let's start with Dr. Corby.
Well, first of all, let me just say how honored I am to be amongst the panelists for this workshop. It's been a remarkable 2 days. And so thank you to the organizers, as well as thank you for whoever suggested I be on this panel. So for mid-career, I think that there are two parts to that question, Monica. The first is what do those that are training our most precious resource, that our early career investigators in the scientific space, need to be thinking about as they train them, and also as they are looking to advance equity within their work. The last few years of this pandemic has really highlighted that we all need to be in this fight to advance equity. And as folks are starting to turn towards that and think about their own work, how can they reposition themselves to do work that advances equity? So I'll start with the first. I think one of the things that I have talked about in terms of mentorship and is that there's just not enough people of color, scholars of color to go around. And for those of us to do health equity work, we tend to be overrepresented in the amongst people of color, primarily often because folks have had a lived experiences to do this work. And it's often purpose-driven work. It's typically not solely for, scientific, the benefits of scientific discovery. And so the recognition that there's, that passion is not, it's typically thrown out as almost a derogatory term. Oh, they have a lot of passion. But it's really, the way I look at it, it's purpose-driven work, that we are in this as scientists to really find ways, using our own skills and expertise as scientists to advance health, so that everyone has an opportunity to be healthy. That can happen. On one of the panels earlier today or yesterday, there was a question about whether everybody should be doing community engaged work. And so to me, we no longer have the luxury of just sort of navel gazing as a scientific community. We need to ensure that our work, regardless of whether we're doing basic science research or whether we're doing, phase 4 translational research, we need to be thinking about the handoff, the end user who is picking up this research and then using it for the next set of scientific discoveries. And for our basic scientists, that may be clinical investigators, that may be, we need to be thinking about who it's being handed off to. And that, as we think about stakeholder engagement or community engagement or translational research, to me, that's one of the things that scientists, mid-career scientists, need to be thinking about. The other thing is that there's this, there's a very fragile period when people get their first R01. And I think we need to be shoring up and supporting our early career investigators as they make that transition point. So for mid-career and senior investigators, they need to be thinking about that. We all have seen the data and the studies that have shown that scientists of color are often researching topics that are less likely to be funded, and even when they are looking, even across the board, they're less likely to be funded in terms of their first R01. And so that fragile period is even needs to be even more protected for scientists that are in that area. In terms of supporting our mid-career and early career investigators, I think that we as mentors need to do a lot of work to understand our own biases when it comes to scientists of color. Oftentimes when I hear about the retention and recruitment support of scientists, young scientists of color, what I hear about, and as a way to promote inclusive excellence, I tend to hear remediation, that, we need to give them the skills that they need to be able to succeed, as if, in my view, we have already identified the cream of the crop. We have identified individuals have grit and determination, have often been able to transcend some of the most challenging and compromising circumstances to sit at the same table as any other scientist. And that expertise, that grit and determination, I think needs to be celebrated. There may be gaps in educational attainment because of the work that they've had to do, sometimes real work, working during high school, working during college, that didn't afford them the kinds of opportunities that others might have had. But the genius that I see to be able to transcend those obstacles is often not celebrated. And so that, to me, is I think people need to check their assumptions about why remediation might be needed. It's not remediation as if folks can't learn the skill set. They've already demonstrated that they can be successful. They're sitting at the same table, having overcome all kinds of obstacles and challenges. And so now we need to celebrate and make sure that their toolkit is full and that they have the same opportunity as everyone else. This is not only an individual issue, it's a systems issue in our institutions. I'm going to pause there because this is a soapbox I can stand on for a long time. So I'm going to let my colleagues jump in.
Well, you stand on it very well. There are lots of gems that you dropped and important phrases that I hope everyone is catching on to. I know very important words that you've shared and just experience that you have. We know you know what you're speaking about. I'd like to hear from Dr. Belcher and your thoughts to add to this question about how we support or how we encourage established or mid-career researchers who are just getting into this and who are training others.
Well, I think it's vitally important for us to continue learning throughout our career so that, I'm very fortunate because I am a pediatrician and I still see patients. So it's really the patients and our young scholars that are inspirational to me and help me to move to those other spaces. And I try to encourage my colleagues to come along with me on that journey. So I think for over a decade, as part of the Maternal and Child Health Bureau, they had a learning collaborative to promote diversity in the maternal and child health field. For me, just sitting around at the table is not enough. I have to do something. So about 13 years ago, we created a a conference, Room to Grow, Journey to Cultural and Linguistic Competency, that was designed for our LEND trainees at Kennedy Krieger Institute so that they could continue to learn. But also we had a lunch and learn for faculty so they could be in a private space and we could go from safe places to brave places. Because what I try to tell my colleagues, what I want them to understand is that there's discomfort at the learning edge. And if we stay in this comfortable place and keep doing the same thing, we're going to get the same results. We are not going to eliminate health disparities. We're not going to be able to bridge what we see and correct it. So we have to continue to listen carefully to our patients and the young people who are often a little ahead of us in our older selves, to be able to innovate. I also think we cannot stay in the ivory tower. I'm a professor of pediatrics at Johns Hopkins, and again, the vice president at Kennedy Krieger, and we can't stay in the ivory tower. We have to be able to work in the community. We have in Baltimore City, we have a task force for the Baltimore City social determinants of health, where community and faculty and researchers can work together to identify what we say is the social determinants of what we see. The political determinants are how we got there. So what do we need to do to advance the health and well-being of the citizens in the city where we work? So doing that type of partnership, equal partnership, working on local community health improvement coalitions is, I think, where we are a good learning space for us as mid and later career researchers.
If I could jump in and just underscore something that my colleague Carolyn is saying, this idea of lifelong learning as a mentor and a senior scientist, particularly when it comes to mentoring and supporting and being a sponsor, not just a mentor, and also a sponsor for a faculty of color, I think is critical. It requires constant reexamination, particularly if, for all of us, frankly, because we're all on this journey around equity and diversity and inclusion. And it requires even more intentionality for those that are not BIPOC faculty, to be willing to reexamine, and particularly in that space, that brave space that Carolyn talks about, particularly being willing to feel uncomfortable, get uncomfortable, not just feel uncomfortable, but go so far as to make yourself uncomfortable, to understand the lived experience of your mentee, and also to examine your own biases and failings and gaps that they may have in terms of their life experience in dealing with people of color.
And I think one thing that's really critically important is that particularly in academics, that we get the support and that mentoring is valued, and we get the academic reinforcement and encouragement to do that. Even if you look at the training grants across the institutions, you'll see that maybe you get an 8% indirect, but it takes a lot more time than that 8%. When we look at what we value, if we say we value mentoring and T32s and things of this nature, then the infrastructure support that has been required over the last 2 decades that I've been doing this work has increased. There's more clearance process, there's more registration and verifications and things of that nature, which are magic to people outside, but it takes a lot of time and investment, and particularly for our BIPOC faculty, as you were mentioning, that oftentimes this is done on off hours. So on those 50, 60 hours, 70 hours a week, because it's so important and we can't afford not to do the work.
And we disproportionately and gratefully mentor our young scientists of color. They're seeking us out oftentimes beyond, from all over campus, frankly, and
the world.
In the world. In the world, Carolyn.
In South Africa.
Literally. Exactly. It's at least 3 or 4 emails a week that we get to please meet with me, please talk to me. And we have to build our own systems to be able to support those up and coming scientists. And even something as small as putting in a training grant, filling out those trainee tables. We have hundreds of people that we need to put in those tables. So it's just even thinking about
the systems.
Thinking about the systems to be able to support mid-career and senior faculty of color to be able to do this work as well. But this panel is supposed to be talking about early career. So
you're right. But that's important, I think, just to all the points that you've made have been very important to move to that next part of this conversation. So for the rest of the time, we will focus on how we encourage and work with early career scientists. So let's, I'll direct the next question to start with to Dr. Plaisamy. So based on your expertise, your experiences, I'd like to move us into some of the hows, right? Because we hear a lot of the words, and sometimes it even almost seems like buzzwords, but I think people need to really have a better sense of how these things happen. So it'd be great if you could share with us your thoughts on some of the approaches, some of the strategies specifically that can be implemented to encourage and empower early career scientists or researchers from diverse backgrounds, regardless of their career stage, to engage in community engaged research in general, and also with a focus on addressing health disparities.
Yeah, that's a great question. Early on, I realized while I was at Howard that there are endless opportunities at the NIH, and the NIH itself is confusing and complicated. And so I decided to just explore the website and figure out if there are opportunities for young scholars like myself to get involved and to really get an in-depth experience. And so I participated in the Health Equity Program, which matches young scholars with an institute, and you're able to connect with a mentor. And I was fortunate to be matched with Dr. Melissa Green Parker, who really transformed my idea of what an early career investigator is. She took me around NHLBI, got to meet Dr. Mensah and learn from great folks by attending workshops and meetings. And so that hands-on experience and taking the risk to apply to different programs really cleared, I guess, the pathway or the vision of what are the possibilities available to early career investigators. And so I guess one of my takeaways or my advice is to do the research and to find out the different opportunities and programs that are available, but also too finding a mentor who is invested and willing to take you around and shake hands with folks in different departments. Dr. Melissa Green Parker was really influential in that space, and I was able to connect with different people and learn about the different opportunities that I could apply for.
Great, thank you. So let's talk a little bit more about some of the specifics. You did mention the Health Equity Research Program, so that's one great example. Dr. Belcher, will you talk to us a bit about your own experiences and expertise with some of the specifics about what can be implemented to encourage early career scientists to move into community engaged research and to know how to do that responsibly?
Well, that is really one of my joys. You talk about a passion area, is to be able to share the work. My patient population is primarily those children who are at risk for having developmental disabilities. Specifically, it's been working with families who have a history of parental alcohol and drug use, as alcohol use during pregnancy would be the #1 preventable cause of intellectual disability. And it's not just as simple as just say no. So being part of the community, developing programs that are embedded in the community, actually going to the community and working with the families, listening to their stories and trying to expand the services that are available where people live has been great. And then bringing residents and scholars along with me and seeing the difference that you can make by being there with families and providing services and not For instance, when I was part of the program that I had developed when I was at University of South Florida was called STRIVE, Support, Treatment, Rehabilitation, Independence, Values, and Education. But I would not hire a social worker who wasn't willing to go to the community. And I went to the community and did home visits as well, because you don't know until you do know what the challenges are. So in doing this work, I was working with pediatric residents, but also I understood it's a multidisciplinary endeavor. So I was able to get CDC funding for undergraduates through graduate and postdoctoral students, through the Dr. James A. Ferguson Emerging Infectious Diseases Fellowship, through Rise Up, or Research Initiatives for Student Enhancement undergraduate program, and then through the Office of Minority Health, through the EMERGE, which is Excellence in Mentoring Underrepresented Groups Health Equity Fellowship, which we place fellows for a 12-month period at any of the HHS agencies. So we have one at NIH, we have 3 at CDC, we have 1 at SAMHSA, 1 at HRSA, 1 at OPA, and then really giving young people the opportunity to have a mentor. Mentoring is a critical part of the services. So not only do they do the research mentoring, but we have a mentor coach, and we have a framework that we work on, which is a culturally congruent mentoring framework where we value the individual scholar's lived experience. And just because people look alike don't mean they have the same lived experience, and we have to recognize that. So they work with historically Black colleges and universities. I'm a graduate of Howard University, so I've never gone too far from that. But tribal serving institutions working on their First Nations on the reservations and working within the community. So I think that really helping young people and having mentors that look like them and creating near peer mentorship pathways is critically important.
Absolutely critical. Dr. Corby, could you discuss examples of programs or initiatives that you're involved in or aware of that have effectively encouraged early career scientists or investigators from diverse backgrounds to focus on community engaged research or CBPR? And then if you could also talk about why and how those programs have been effective.
Well, thank you for that question. So what I'll say is that there are a myriad of programs that to build the skills of early stage investigators. I think that we're seeing an expansion of understanding how those skill sets support research that is community engaged. So community engagement is not necessarily a methodology, but an approach. It's a way of looking at the work. We still use the same rigorous kinds of research methodologies in any other sort of clinical, translational, or population health or health services research. But it's the recognition that we need to center the voices of those that are either most impacted or are the end users of this work. So the Health Equity, Health Disparities Research Institute by NMHD is a fantastic one because it does give this sort of full breadth of clinical research to population health research. I would say K24s. I was a beneficiary from NHLBI of K24 as well as a renewal, and that to me was a phenomenal opportunity for me as a mentor to create an infrastructure for that work. The infrastructure that I built had to do with around community engaged research, because that was what I was doing at the time, and ensuring that we had an infrastructure, even though we had our own studies going on, that we had a platform for junior and early stage investigators to come on board to be able to do their research. One of the things that has been mentioned numerous times over the last 2 days is that precious resource of time to be able to build trusting, authentic partnerships and relationships. And typically a fellowship is 2 years, maybe 3 years, depending on the type of funding that you have for an early stage investigator. And it's not enough time to build those relationships. So as senior investigators, having that infrastructure of an ongoing partnership, the Project Grace. The partnership that I've been a part of, it has been going for almost 20 years now. And we've had junior folks come on. We focus on pretty much cardiovascular disease, HIV prevention, chronic disease prevention. So there's lots of room for lots of questions to be asked, as well as even with that broad swath of what we have focused on, there are all kinds of things outside of that that are still inequalities that need to be addressed scientifically, interventions that can be implemented. And so we provide that trusting relationship. Typically myself or one of the investigators in our partnership are one of the mentors, and one of our community collaborators are also co-mentors with our junior folks, our postdocs, et cetera. We also use diversity supplements very frequently to our R01s that are funding the work that's occurring in this collaboration. And so we have had diversity supplements for postdocs all the way through to junior faculty. We've tried to get we're working on one for high school students, because we actually have one of our R01s that's funded by NHLBI is supporting a youth asset mapping program, MapScore, and taking those data and putting those data into the EMR. And so it's a tiered mentoring program, as Carolyn points out, the sort of near peer mentoring that's happening for high school students and college students in that program. So I mean, in my experience, there are lots of stuff out there to be able to get research skills, and many of those are expanding their aperture to include community engaged research and the ways that those methodologies can be applied in community engaged research, and the application of that knowledge in real time with a research infrastructure that doesn't require 18 years like I have been able to be a part of to build. And I will say that one of the benefits of layering on a strong and existing collaboration is that when that person goes, when Marie leaves Harvard, or when she would have left North Carolina, that partnership is not bereft, right? It's not severed. We are able to keep that work going. We are able to keep that collaboration going, and which is one of the things that I was concerned about in this research, is that people are at how academics, we come to a place, we're there for 2 or 3 years, and then we move to another place on our first real job, and those collaborations that you build during fellowship with communities can be significantly negatively impacted if you're moving again away from that. And leaving the community.
And the trust, right.
Yeah, less well off than they were when you started.
On that point, I will also just ask you, Giselle, that, this notion of people moving and what happens to those relationships. I think, part of the, at times, unfortunate reality is that for scientists who are underrepresented, racial, ethnic minority scientists seem to be more likely to move more frequently, right? Because of institutional factors and other things that lead to that. But then this is also the group who's most likely to form, especially working with populations that experience health disparities, those relationships. So how, so that creates a complexity of doing that. Can you talk about that at all?
Yeah, so that's exactly why we've created this infrastructure. Our partners expect, in fact, our community collaborators expect junior folks to come in and come through our partnership, knowing that we're the anchor for the collaboration, knowing that I'm not going anywhere, at least as far as I know. Nobody's told me that I'm going anywhere, that, we are here, and our work, our R01s, our, center grants, those are the things that form the foundation of it. But the diversity supplements, they understand that these are junior people that they are training. It's not just me training, they're training them. They are co-mentors. They have been co-mentors in diversity supplements, in K awards, et cetera. So it's really elevating, to me, it's elevating that expertise of the community leader and collaborator to also be a mentor in this work, because they have such tremendous expertise to bring.
Got it. Okay, great. So I want to move along to the next question here. And I'll start this question with Dr. Placini. So we've heard and through several of the comments thus far about the importance of trust and trustworthiness and meaningful engagement, which are all components of inclusive excellence in community engaged research. So how can we build the capacity of our early stage investigators, as well as, our diverse researchers who are from diverse backgrounds, regardless of their stage, to really establish those connections and collaborations with community partners that are based on trust? And we talk about that takes, years to develop. And I thought that the example that Dr. Belcher offered about bringing trainees into the community and on home visits. But even before that, how do we train early stage investigators on how you even start with building these kinds of connections and getting, community partners to trust you, that you are there for the long haul, you're not helicoptering in and out. And how do we just get that process started?
Yeah, I think a lot of it involves having honest conversations, and we've already highlighted this earlier, honest conversations with our team members and our honest conversations with ourselves. Lately, we've been hearing conversations around structural racism, but really dissecting how does structural racism impact different health outcomes, and having honest conversations about that. I think that's so important early on, so that folks can have, a common ground when they are preparing to design an intervention or a community assessment. And also part of that too includes great mentorship. And I think that too has been involved throughout the conference. In order to even get to having honest conversation with yourselves, it also includes having honest conversations with mentors of what is possible, what is not possible, what sorts of connections or opportunities are there that I could connect with. And a lot of that involves doing your own homework and having those honest conversations with yourself as well.
I would say it also requires humility, the willingness to realize that, we don't have all the answers. Right. If we had all the answers, we'd already be sort of at that point of equity, right? So this is we talk about the power of multidisciplinary, interdisciplinary, transdisciplinary kinds of research. And this is fundamentally what community engaged research is, to sort of the nth extreme, right? Is the recognition that we need all of those perspectives around the table to come up with the best solutions.
And I think for, again, as the pediatric example, in working with Head Start, then you're shaping, you're asking them, well, is there some way that we can help to move the students forward, move their educational preparation forward, and what having meetings with both the parents and the staff that's in Head Start, and then actually not bringing someone else in, hiring them, but saying, are there family service coordinators here that want to learn a new intervention or learn a new skill, and then it stays embedded in the community after you've left. And so that was really one thing in a variety of the different studies that I've done that are community-based, is really trying to look and see all of the talent that's already there, and those who are open to continuing to learn. I think that is important in our research design. Also, what I try to do in the programs that I have developed for undergraduate all the way through graduate students is to elevate CVPR, to say, what really is hard science? Why do you all call that hard science and not this? This is hard science.
Harder.
That's why.
This is all that hard plus.
I know. I have never had a tissue culture talk back to me. I've never had them talk back to me. But
Call me on the weekends about what I did wrong.
I can't come here and do that, Dr. Belcher. I don't like this and I don't like that. But what we do is we have research accountability groups, and we bring our students who are doing bench research and those who are doing CVPR, we bring them in the same space, and then we say, okay, what is the research design, the question, what are the challenges? So they get to respect the difficulty that each one of the challenges that each one has. I had one student who, I will just say, she was like, well, Dr. Belcher, I don't understand why I'm sitting in here learning all about health disparities. And as I say, the social determinants of our health are what we see, the political determinants are how we got there. I don't see why I need to do that, because I'm the best thing since sliced bread and on the bench. And by the end of her session, she was like, oh my gosh, if I develop this great medication, vaccine, et cetera, and I am not trusted by the community, and they don't, and I don't get it, they don't get it, and we have not promoted health and wellness. And I mean, that was the best thing that this particular student could have told me, that, you know, because she was just like, very dismissive. I was like, oh my goodness. But by the end of the time, she was like, I hear it. I see you. I understand.
And that is such a powerful story, Carolyn, and so poignant in your willingness to hold that student's hand, because it does. In science, we are rewarded for that bravado, right? We are rewarded to walk around knowing like that we know what we're doing, and that's just not going to fly when you're doing community engaged research, because the reality is none of us really know how to fix these things. This is just a best guess. That's what hypotheses are, right? This is our best guess about what we think is going to happen and how things are going to turn out. And
it's the humbleness you were talking about.
It's also the humility, and you know, what I have been telling folks is, you know, all of us come from communities. All of us have family, friends, grandmas, somebody that you got to explain what it is. I don't know how many times I had to explain to my father, who just passed away. So what is it you really do? Do you still see patients? Yes, I still see patients, but only a little bit. So to be able to explain in just regular language what it is that we do, it's remarkable that how acculturated we've become in the scientific world, and sort of that ability to straddle both areas, being in and of a community as well, and of a science as a scientist in a scientific community, is really, frankly, in my view, one of the most challenging as well as the most rewarding and transformative for me as a scientist in being able to do this work.
And that's why I'm so excited. Oh, I was going to say, I'm so excited about the work that Dr. Blessamy is doing in helping us to be self-reflective on interracial anxiety, on going to some of these learning edges and thinking about, I mean, now we're all talking about the glomerular filtration rates. We're talking about our pulmonary function tests. We're talking about, we don't have the instruments that measure pulse ox across different pigment tones, you know, that maybe we were sending Black folk home from the hospital during the pandemic because our pulse ox measurements weren't accurate for the skin tone. And these are things that we can correct. But if we're not thinking about it, if we're not questioning ourselves, if we're not humble research-wise, we're going to continue to do the same thing, get the same results. It's not acceptable now. We really need to, you know, have the young folks maybe do some of that innovative thinking and leading for us and thinking about the work.
Let me ask another question, just thinking about all the things that you're sharing. And one aspect of this question that we're talking about now that I really do want you to hone in on a bit more is the reciprocity in the relationship with community partners. And that, you know, it's we want them to trust us, that we're not going to, you know, be harmful, we're going to be helpful. But there's a reciprocity in that. And we talk about being bidirectional, but how do you explain to everyone in the room and our early stage investigators moving in this direction about what is the reciprocity there, and what should community partners expect from you as a scientist doing this work, other than, you know, we'll return the findings to the community, or, you know, how does that really play out in real life? Anyone, this is for anyone.
You know, I think some of it is that our community members can see our growth, can see their voices reflected in the work that we do. Again, you know, I just will recall a circumstance where I was working with a church-based group, and they, as part of their mission, what we were looking at is, could we provide developmentally appropriate intervention to foster parents who, this was their mission. The church's mission is to help in the community for infants, babies that were HIV positive or had intrauterine drug exposure. So we would go to the parish hall and do developmental assessments and parenting. And I think that there was a connection there when you're working in the community as part of the family. And by the end of a couple of years, we used to be, we would be in the kitchen, and any place in the parish hall we could do an exam with the child. At the end, they created, I mean, it's very touching. They created a little chapel that was a children's chapel, so that we could have a place that was, you know, our own, that was more child friendly. I think that those are the things that, you know, really make a difference in changing the whole community and part of the family in the work that you do, and know it will continue because it's, you know, there to this day. So.
Yeah, I that's beautiful, Carolyn. And so much of that is, you know, I remember years ago, I was on a panel with Bettina Beach, and she talked about showing up when you don't want something. You know, not always showing up because I have a grant and I need a letter of support, or we have this project and we're working on it. It's showing up when you don't want anything. You just
want to be
in relationship, right? To being there when you get that call and being willing to stand in the fire, right? The when you're getting dressed down because of something you did or didn't do, or something that somebody from the university did. You know, I remember some people at UNC were collecting, you know, cheek swabs for a genetics study, and I got called by one of my partners, and he was like, your UNC researchers are here, and I was like, wait a minute, what? What are you talking about? And I had to go and figure it out. I had to go find out, research this, come back and get that information and put him in touch with this investigator and broker that relationship. It wasn't something I was doing, but it was my obligation
to be there.
So it's showing up when you don't want, and being there when something is wanted.
I love it. All right, I'm going to ask one more question because we do want to have an opportunity to answer some questions that have come in so far and others that may come in. So pretty quickly, for each panel member, when you think about the future of community engaged research that applies a health equity lens, what is one message you would like to give to investigators currently working in or considering entering this field? Let's start with Dr. Belcher.
I'm going to steal Dr. Corby's humbleness. So no, really, I think that being open also is not having all the answers, and being an active listener, keeping your eyes open, really seeing people and being in the moment. I think those are all really important learning lessons. I think recognizing the strengths in the community, the strengths instead of a deficit model is. And I try to be very solutions oriented and seeing the strengths. I know because of my family history and those that I love, what people have endured to get to this point. So, I just respect the journey.
Great. Dr. Plaisamy?
That was beautiful. I think in addition to sustainability, it's so important to think about dissemination. It's so often that we are, I guess, obsessed, I'm going to say, with trying to find the perfect grant or publish our findings in the top journal, but there's so much data that we have that isn't readily available or accessible to different communities. So how do we use social media, different forms of technology to disseminate the information that we have in a digestible way for our work to be meaningful and to have the impact that we're intending to do, and stepping outside of our academic silos and realize that there are people at the center of this work. And so I guess it's twofold: sustainability and dissemination. How do we take it outside of the ivory tower or these academic spaces?
Policy.
Right, exactly, and bring it to the folks that can really translate this information in a meaningful way.
Thank you.
Can you repeat the essence of the question? Is this lessons learned or take-home points? Or
It's one message you'd like to give to investigators currently working in this field or considering entering it.
I will go back to the Audre Lorde quote: "The master's tools will never dismantle the master's house." And so for us to be able to advance health equity, for us to even be thinking about inclusive excellence, we need to have new paradigms. We need to be innovative in the ways and not bounded by the paradigms, theoretical frameworks, conceptual models that have been passed on over and over that have led to the recapitulation of so much health inequality. And so I would say that if we're going to dismantle the master's house, we need new tools.
Amazing, amazingly well said, all three of you. So I'd like to turn it over to our moderator, Dr. Salazar, to pose any questions that have come into the chat.
Yeah, thank you all. That was really an outstanding conversation. I really learned a lot, and I'm very appreciative for all of you taking the time and sharing your wisdom with us. So we do have some questions from the audience. So one of the first questions touches a little bit on health equity tourism, and states, it's from Luz Garcini, who states, often community engaged scientists from underrepresented backgrounds must also act as gatekeepers to our communities and protect from investigators who do not represent or know the community, but want to jump on the train because of growing funding incentives. So what advice do you have in this regard for coping in these situations, particularly for early career investigators?
Yes, I can answer that question. It's something that myself and my cohort here at Harvard are really thinking about, that Dr. Coletto is at the forefront of leading this. He's actually designed a tool where you can figure out who is invested or who are doing projects related to racism. And so you can put a person's name in the tool and you can see how many publications, how many grants have they had that are related to your research topic and to racism. And you can see if there is longevity. And so that helps build transparency to see like who's actually invested in this work and who's not. And so we're really excited about this tool that he's really been at the forefront, and hope to disseminate that in the future.
So isn't that clever, and making it scholarship?
Exactly.
So one thing I also would maybe recommend or say is for the NIH, when you're filling out the forms and everything, you have to put who your population is going to be by race, ethnicity, gender. I don't know whether they have all different genders, but all of these different categories on those back sheets. But when you look at the researchers, you don't have that same information. And sometimes if you're thinking about it, if you go from pre-contemplative to contemplative, you might walk down the hall a little bit further and get to know some of your other colleagues who may actually be doing a little bit more of this work if this is new to you. So you want to create this network of colleagues who are able to work together and to grow together in this space. But this is a very important question, and there are a lot of programs that are coming online because they're just seeing the light, so to speak, and it's not always easy to say, because many times people who have NIH funding continue to get it, and we were in a conversation actually the other day in terms of looking at review panels and the diversity of review panels and the bias in review panels for NIH grants, and kind of thinking across the different systems of funding where there may be some bias or kind of structural and institutional racism and strategies that have been used since the time immemorial. So, kind of looking at our scoring system, who's doing the scoring, as well as who's doing the research and what that demographic looks like.
I would say that there's both a structural challenge. I'm thinking about Marie's colleague, which is a genius tool, and for so many of us early on, putting in the word structural racism in our early work would not have gotten it published, frankly. I remember scathing reviews when I was sort of on a paper that I wrote, suggesting and advocating for moving from just minority inclusion in research to advancing health equity, that there should be some intentional bridge. It was vitriolic and more affective than it had anything to do with the science that I was writing about. And so I would just, as we think about those tools, just realize that we've come a long way, and we still have a long way to go. I would also say that there's that affective component that I was describing, that, there's still, and that you talked about, Harolyn, there's still idea of this soft science somehow. I don't even know how that term even got in there, as if somehow as a scientist, I'm going to use things that are less rigorous to do this kind of research. If anything, I'm, not only is it the work is more, but I feel an obligation to bring the highest standards to this work because of the populations that I'm working with, that have been discriminated against in so many other ways. Why would I contribute in that as a scientist in that way? I get deeply offended by that idea of soft science. But for those of us for those of our colleagues who now, the veil has been lifted and all of a sudden they realize inequalities exist, I do still think that there is the perception that this is the easy work to do, that they can just plug in, a variable, a race, a measure of race into their work.
Racism.
Right. Not racism, but some measure of race into their work, and then, do some additional analyses, and now they're doing health equity work.
Right. And then I think from the seminar or the panel that was before us, being very careful with the results that we get and looking at the context. And I think there were a lot of very valid points that were raised in how we, whether we use mixed method, where we use qualitative and components in our analysis, and being very, sometimes the results are nuanced, and be very careful about the conclusions that we draw or can draw from the work. So I think we digress a little bit from the question. I'm sorry about that. But
all right, you got to talk in a bunch here.
Okay, one perhaps last question for Dr. Corby. So in talking about kind of the deficit framework, you mentioned the use of, remediation for young researchers, especially those from underrepresented backgrounds. So the question is asking if you could expand on that topic and share any personal stories or interventions you've utilized that have been effective to kind of combat that framework.
Well, I'll share a story that illustrates it, and then maybe we can, if we have time, talk a little bit about it. I was in an interview process, and we were interviewing a candidate for a senior position, and asked the person about their experience with diversity in a training program that they were a part of, and that person said, yes, I definitely value diversity. We rank, all of the applications, and then we go down to the bottom and pull people up who are diverse candidates. And I thought, well, I'm not going to be at the bottom. I might not even apply if that's the sentiment, that all scholars of color are going to be at the bottom of the list. To me, it just was very illustrative of the idea of what this person thought of scholars of color, that there somehow is some deficit, and not that they're bringing this genius, this grit, this determination that got them at the table in the same way, sitting at the same table as all of these other scholars that didn't have those obstacles to overcome. And so I find that in academia, when we're talking about diversity programs, right, separate from equity, right, we're now talking about diversity, that many of those programs are not elevating the strengths that those individuals bring to the table, that they're really talking about and focusing on gaps, perceived or real, that individuals might have. And it's not elevating, or even, as we think about many of our institutions have programs that to support the diversity of faculty, adding additional resources to a recruitment package, et cetera. And yet those are seen as sort of these affirmative action programs, and now I'm at an institution that the Supreme Court is hearing arguments around dismantling affirmative action in our student body selection. But the idea that there's some remediation, that there's some deficit in the
universal,
scholars,
right?
Yeah, across the board, universal, that there's somehow less than, to me, is baffling. If they've gotten to the table, they have not only as much, but more of what it takes to be successful. It's the institutional and structural barriers that make it so that folks are not able to advance. This is not a deficit of the individual, it's a deficit of the institutions.
So there is a saying, you have to go twice as fast, get half as far.
Exactly. Yep, work twice as hard to get half
Twice as far.
And
yeah.
that's not because the person doesn't know what they're doing, it's because the
So they're
institution
structural.
is not set up to value their contributions.
Right. And then there's those with disabilities. So we have a lot of marginalized populations that have been challenged by the structures that we have. We talk about the GRE. We know that it does not demonstrate how effective you're going to be on the other side of your degree, but it's more like a gatekeeper for, if you've been exposed to a white middle class, upper class upbringing or environment, educational environment, that it really does not have the predictive validity. And a lot of schools are moving away from that. And a lot of the STEM sciences, I'm not going to say hard sciences, all right, and some of those social sciences tend to just grab it, keep it, but the SATs, all of these are kind of structural, and we have the data to prove kind of the acceptance all based on these factors are not valid, actually. I'm not even going to say equitable, they're not valid. So you have to be able to address that.
Well, thank you very much for a fantastic session and taking the time to answer these questions. Thank you very much to the audience for answering our question, for asking the questions and attending the session. And I will turn it over to Dr. Ilias.
Thank you so much, Dr. Salazar, Dr. Webb-Hooper, Dr. Belcher, Dr. Plessamy, and Dr. Corby. This is all of our panels have been amazing, and we ended with an fabulous session. So thank you for doing that. Thank you for participating. And I just want to take a moment to thank all of our panelists and speakers for taking out the time from their very busy schedules to do this and to share their insights. And each of the sessions has been amazing, with so many insights shared that it's going to take a little while for us to unpack all of it. With that, I'm going to go ahead and hand over to Dr. Jinji Zhang, who will be providing the closing remarks. And then my colleague and co-chair, Dr. Fernando Bruno, will close out the last and final day of our workshop. Dr. Jinji Zhang, for their closing remarks, I should just say really quickly, he is the branch chief of the Health Inequities and Global Health branch at the Center for Translation Research and Implementation Sciences at the National Heart, Lung, and Blood Institute. Dr. Zhang, please provide us some closing remarks. Thank you.
Thank you, Maliha. Can you hear me?
Yes, we can hear you.
Well, I just want to really thank you, everyone. Really have a wonderful and inspiring workshop today. Next slide. We want to thank everyone, all the attendees really help us spend really great 2 days with us. Thank all the moderators, our panel chairs, panelists, distinguished speakers, and the planning committee really work hard to make everything happen. To thank the logistic team, technical assistant team, and also our co-sponsors, NIMHD and NIA, for making this a wonderful time for us. Really inspiring. Next slide, please. This is actually a slide, a National Academy slide Dr. Cooper mentioned earlier. Sometimes I myself feel lost in my 20 years public health career by analyzing data, publishing papers, report, following bureaucratic SOPs sometimes, forgot the fundamental reason why I love public health. Today, I'm extremely happy to see we put community at the center of our public health research and make health equity as the key to transform a very heavily market-driven, complex healthcare system in the country. In addition to all the core principles of the community engagement we talked about yesterday and today, and also listed in the National Academy paper, this ACE framework, it will be great to remind ourselves a couple of things our distinguished speakers, panelists mentioned in the workshop. First, of course, diversity and inclusivity is the most important, as we just had in this session. Not only the diversity of research teams, including community leadership, but also inclusivity of the different opinions and the ways to do things differently. A new generation of community engaged researchers are needed. Very critical to building also a sustainable relationship, trust, partnership. Many times building trust may take years. However, growing that trust may only take one night. In addition to all the tools, technologies, big data, innovative outreach strategies, bidirectional learning is important. Personal touch is important. Knowledge is not all from books. We sometimes forget that. Culture, history, storytellings play significant roles in community engaged research. Additionally, change is needed, solution is needed. Reaching out to the community, meeting community members is our first step. If our research cannot reduce disparities, cannot change inappropriate policies, systems, cannot make community healthier, we still failed. Finally, it is critical to build up community resilience, community capacity, and community power. They are the base in responding any pandemic, any public health emergencies. All in all, we are the reason we actually started public health career. Next slide, please. I want to mention this magnificent program again, Compass. Alessio actually mentioned that in his opening remarks. It is really a game changer, effort to bring communities and researchers together. It will let us sort of walk out of our comfort zone to talk to each other, to learn from each other, stepping away from the office in Washington, D.C., stepping away from the academic institutions, university campus, stepping away from local community organizations. So definitely check that out and reach out to us if there's any questions. We are all here to serve, here to support. Once again, thank you everyone for all the excellent suggestions, ideas, discussions during these 2 days. It's just amazing, and your passion will lead us forward. Thank you. I will turn over to Fernando.
Thank you, Shinji. For those that haven't the time or the opportunity to meet me, I'm Fernando Bruno. Alongside Dr. Maliha Ilyas, I had the chance to be the co-chair for the program of this workshop. So although this marks the end of this workshop, I see this workshop as a new beginning. Earlier in the data science session, Dr. Ali Mokdad mentioned that once in a conference when discussing the advances of the field, he was asked by a patient in the audience, "Where were you 15 years ago?" Which is a reminder to us all not to stay idle, stay energized, and keep moving forward because there are others waiting on us. So I sincerely hope that all we've learned from these conversations have inspired us to what we will do in our next steps within this field, lighting up a flame that will propel us all forward. I would like to also thank all of our attendees who have joined us from all over the world in these past 2 days, as well as you watching this in the future as a recording. It is also of the utmost importance to thank our 24 panelists, 6 moderators, and 6 speakers who engage in a profound conversation on advancing the science of community-engaged health disparities research, while also empowering the community voices. And last but not least, I want to thank the planning committee that have been working tirelessly over the past year to make this workshop possible. Dr. Maliha Ilyas, as I mentioned, is one of the co-chairs for this event. Dr. Mary Masterson, Dr. Emir Katipov, Dr. Crystal Hill-Pryor, Dr. Rebecca Roper, as well as our leadership, Dr. Xingzi Zhang, that you just heard from, Dr. Dave Clark, and Dr. George Mensa. And the logistical team led by Rashawn Jones, which include Tatiana King and Amir Amadi and Maisha McDonald, and also thank our partners from the National Institute on Aging, NIA, and the National Institute on Minority Health and Health Disparities, the NIMHD, who also support NHLBI's efforts in community-engaged research. For our attendees, if you'd like to know more about our panelists and speakers from our workshop, please remember that our event website hosts the event booklet, which contains everyone's photos and bios, including our agenda. And that our website will also be the interface where we'll see the recording for today's events and yesterday's events, as well as the workshop summary in the months to come. And lastly, we also ask you to please fill out our post-workshop evaluation. I know Rashawn is getting happy that I'm mentioning this here. So please remember to fill out our post-workshop evaluation, which will inform us to your feedback to this particular workshop and help us also in the planning of future events. So with that being said, I think I can, in a very rare occasion, say that on behalf of CITRIS and NHLBI, we thank you all for your participation and wish you a great day. This has been just excellent. Thank you.